Yeah, that's what you're doing.
That's what
it says, right?
Can't change it now.
End of October. All right, so I'll get started. Let's see. There's no type person in here to yell at me that have to use my phone. Because sometimes they do, they come in and like, you gotta use a mic. If I'm not loud enough, just let me know. This is the education, I don't remember. I call it the education bootcamp, it probably has a different name. This team, this amazing team, much of us have been together for, I don't know, many, many years doing this. And people kind of come and go. But you really have some of the best teachers in emergency medicine in the room. And I hope you take the opportunity to learn from them, because I certainly do. Basically, this is a clinical teaching education bootcamp. We kind of alternate each year with doing a little bit of clinical teaching, and then sometimes we'll do like more didactic or procedural. And so we do this. We do something different every year. So if you like it this year, come back next year, because it'll probably be completely different, which is what we kind of aim for. Let's just do quick introductions, and then around this table, so stand up and introduce yourself, and where you're from, maybe what your primary or secondary role is that people might be interested in. Go.
Alvarez, I'm the Director of Wellbeing at Stanford.
I'm Susan Promes. I'm the Chair of Emergency Medicine at Penn State, Michigan.
I'm Mary Haas. I'm the Medical Education Fellowship Director at University of Michigan.
Steve Cico. I am the Associate Dean for Graduate Medical Education at the University of Central Florida, and I'm PEDS Emergency Medicine.
I'm Jason Wagner. I'm the Vice Chair of Education at WashU in St. Louis, Reform Program Director.
I am Ben Schnapp at the University of Wisconsin, and I'm also the Graduate Medical Education Fellowship Director.
I'm Jazmyn Shaw. I am a rising fourth year and soon to be Chief President at the University of Cincinnati.
Hey, Robin Hemphill, Chief Staff, Cincinnati VA. And I'm Sally Santen. I'm like. Wait, Sarah.
I'm Sarah Williams. I'm also a recovering program director, and I now run the coaching office at Stanford School of Medicine.
There we go. Sally Santen. I'm a faculty at University of Cincinnati. Okay.
I think cat herder.
What'd you say?
Professional cat herder.
Yes.
I'm not doing so well. All right, we're gonna jump right in. I mean, we're hoping to learn from you all, and you learn from each other, and that we have fun. Right? I think those are kind of our goals today. As someone said to me, I'm an educational socialist, and so as official cat herder, I'm going to make them the educational socialist. And what that means is you should take what we have and use it, right? We should share and share alike. I think we just ask that you attribute us. And it might be nice that if I use Robin's slides or Sarah's slides, or I'm doing something related to that, just let them know. But I really think that we have a responsibility to make the profession better by sharing what we have, as opposed to being ownership about it. Now, I don't know if everybody feels that way in my group, but I'm going to kind of set that as a platform that please share and use what we have and make your group of
The socialist cat herder.
You're out.
Okay, you're next.
All right. I like to start these sessions with an activity, kind of warm the brains up a little bit. So we're going to do a little visualization. I see some familiar faces in here. So if you've done this before, I encourage you to play along and do it again, because the results will differ from what you've maybe done before. And please, we're gonna share a little bit when this is over. So actively participate. We'll do a visualization. So if you need to close your eyes for this, feel free. If you don't have to, that's fine too. This is something called the cube test. I don't know if anyone's heard of the cube test. But I want you to all get ready to visualize and imprint this, because I'm going to ask some of you to recall this. So don't just kind of gloss over the details, okay? So I want you to imagine that you are in the desert, and in the distance are a set of mountains. And in this picture, there's a cube. Think about the size of the cube, the details of the cube, what it looks like. By the cube, there's a ladder, and there's a horse. And think about these things in relation to each other. And there are flowers, and then finally there are clouds. Imprint that. All right, now I'm going to ask for you to share, because I have one of my graduates here. I have to come out. Do you want to share your image for us?
Sure. Let's see, I see, there's a mountain right in the middle, it's pretty high, and then there's what looks to me like a Rubik's Cube on the right-hand side, there's a ladder going right above it, and then.
How big would you say your Rubik's Cube is?
My mind is very small, but in the distance, it's probably about this little.
Tiny little Rubik's Cube.
Yeah.
People love the Rubik's Cube.
So the first thing that came to mind. And then the horse and the flowers are right next to the left side of the mountain.
And what is the size of the horse in relation to the Rubik's Cube?
Oh, it's actually bigger than the Rubik's Cube.
Okay.
Quite a bit.
And the flowers, what are the flowers like?
They're like next to the horse on the ground.
What kind of flowers? What
Like
can you describe them?
yeah, yellow, pink, purple bouquet. You would see like a cartoon of that sort of.
Okay. And then finally, the clouds. Can you describe the clouds?
They are, it's more like shadow of the clouds, and they're kind of just like a little stuff inside.
Okay. What kind of clouds?
It's not the cartoon kind, it's more like in what's that movie with the sand and the Mummy?
Okay. All right. Thank you very much. All right. I'm going to pick on you next if you want to share your scene with us.
Thank you. First, the landscape, when you said a desert with mountains in the back, are you thinking about what I would see if I stepped out of my emergency room?
Which is where?
Northern Arizona, in a place called Kayenta on the Navajo Reservation.
Okay.
So I just stepped out of the PR door and I'm looking at, I can see some of the peaks of Monument Valley off in the distance, and we have flat desert floor. And of course, there's flowers growing this time of year, you need to say so. They tend to be red and yellow and little bunches of grass here and there.
I'm going to focus you in a little bit. So can we start with your cube? What does your cube look like?
It's like a drawing of a cube. I'm kind of made of heights, I guess. I'm kind of slowly rotating up there, maybe 10 feet off the ground. It's
Interesting.
kind of a
Okay.
weird thing to have there. I've never actually.
Be a weird thing to see when you step out of University Park.
But there's a ladder leaning up against it. Whenever where the ladder touches it, it holds still. So it starts rotating. And there's the horse I can't even see.
Literally?
I don't actually ride a horse there, but there are horses all over that front pasture between us and Monument Valley.
And I forgot to ask, what does your horse look like?
Oh, my horse is a bay.
I don't know what that means.
That means that it's got a brown body and a black mane and tail, and it's wearing a western saddle. And I don't have any punches on the bridle.
Okay. What about your horse?
It's rock eyed.
It was like a brown horse.
Another beige now.
Not all brown horses are bays.
But all bays are brown.
Yes.
Okay. Okay. And how about your flowers? What do they look like? And was it? You mentioned scattered flowers. Is that what you had in your vision? Was scattered flowers?
Yeah. People think that maybe the desert doesn't have much vegetation, and we have some. It's just usually about 5 feet away from the next vegetation. And so there's little clumps, and some of them are the kind of an orange color, like my necklace, and they're called Indian paintbrush. And there are other little yellow flowers that are more like buttercups, except that they have a spiky bush that's about as tall as my forearm. And there's a whole lot of them right now this time of year. And there's a few other kinds, but I don't know them by name.
And I think last year in clouds, what did your clouds look like?
They're the little poofy clouds that when they glom on together, they become cumulus, but I call them pillow clouds.
Okay.
We've had lots of them all week.
All right, so I do this activity for a couple of reasons, and one is that I think a lot of times that we think of ourselves as educators, but we don't think of ourselves as creators. But you all just created a vision in your brain just now. You took the same stimuli and you created two very different scenes with the same input. And so the other part of this is to demonstrate that when you're teaching, hopefully it's not the mummy cloud. When you're teaching, you may give people input that you think is very specific and delineated, and I give them A, and out of the other end comes A. But when you give them A, sometimes what comes out of the other end is Z. And so you have to be cognizant of the fact that where people are, what they bring to the area where you're teaching in any given moment affects how they learn, what they recall. And I think also the fact that you will recall different things. Has anyone done this with me before? Like I said, I've seen, this group has, I guess, but yeah, the teaching fellowship? Yep. What you did then is different, and what you all did a year ago when we did this is different from what you did today because your current events affect it. And kind of the woo-woo of this is that you're supposed to be the cube, and your partner is supposed to be the ladder, and your friends are supposed to be the horse. And so the proportion of these things is supposed to represent where they are in your life. So like you're this little tiny Rubik's Cube in your life. You're hovering majestically over your emergency department. And sometimes it's like a giant Rubik's Cube and a little tiny horse. And you're like, well, it says something about your friends. But so anyway, today I want you to think outside of the box. I want you to recognize boundaries that you may place around the way that you think and work, and let's try to knock those boundaries down and have a good time today. And hopefully you will be able to take some of these things back where you're going and teach other people, including the cube test. Feel free to steal it, because I stole it from somebody else. I guess you got the mic.
Do you remember what that was? Let's see.
Open already.
Is it this one?
You can continue thinking about the box
Yes,
and the
think about the cube.
as they're trying to figure out this cube here.
When is it?
So, maybe the top one.
This one?
I thought you
So
had
the horse and the cube meet in the desert.
Yes.
And do you want lavaliers? Because you don't want to be.
Yeah.
Yeah.
And the horse doesn't cute.
Weirdly responsive. It is weirdly responsive.
The best part of you is just in front of your tail.
I turned it off. Yeah. We're going to have to laugh. I turn it off.
I don't have a good place to put it. Be the cube, be the cube. All right, so I'm Sarah Williams, and this is Ellie Alvarez. We're from out at Stanford. We have some goals and objectives, right? Getting meta now, okay. And these are some goals and objectives of several of the upcoming mini talks. I just want to kind of introduce you to them. So by the time that we're done with this, we're going to be reflecting around why we teach at the bedside and why we don't. We're going to be thinking a lot in this section about learning climate and the type of environment that we are creating for our learners and ourselves, honestly. We're going to talk, in this talk and several talks that come up, around how you can prep in advance for your shift. We're going to be talking about SPIT and teaching scripts. That's going to be covered in one of the upcoming talks. We're also going to be looking at an approach to just-in-time teaching, especially for procedural skills. And we're also going to be talking about feedback mechanisms and using a coaching approach to feedback, right? So we're going to be going through quite a menu of new strategies that you can use in your teaching. The first thing I'd like you to do as we think about learning climate and we think about what it takes fundamentally to be a great educator is I'd like you to do this exercise. Everybody grab this QR code.
There's the horse. That horse keeps going round and round. The first thing I'd like you to do is just like you thought about the cube, I'd like you to imagine, I'd like you to remember the face of a particular educator who was really effective for you as an individual. And it can be anyone from grade school on, grade school, middle school, high school, college, med school, residency, now, right? Give me a signal once you have a face in your mind. Got somebody? Okay. Now I want you to think for just a few seconds about what it was. What was it about that person that made them particularly effective for you?
Just come up with a couple of words.
Organized.
Organized, okay.
Curious.
Curious.
Invested.
Invested. Energetic. Love it. What else? Safe. Calm.
Honest.
Honest, down to earth.
Knowledgeable.
Knowledgeable. Organized. All right.
Present.
Present. Engaged. All right. Are these words resonating with you? Do they apply to the person that you thought about? Right. What's interesting is I've given this talk now in many places all over the country and to every level of learner, from a brand new medical student and PA student all the way to the most seasoned faculty, and the answers are always the same. What doesn't come up is they don't have to be the smartest person in the room. They don't have to know it all, right? And I think we sometimes hold ourselves to an impossible standard, and that we often hold ourselves back as educators when we're trying to teach, because we think we have to be something that we're not. So this kind of encapsulates what we just talked about. 7 Habits of a Highly Effective Teacher spells out teacher, okay? That you teach, that you're enthusiastic, that you give targeted appropriate feedback, that you're centered around the learner, helpful, that you elevate them to become independent, and you role model, right? So we're going to take a minute now at our tables and introduce yourselves to each other. And just kind of say a little bit about who you are and what is it about being an educator that brought you here today. What's your favorite part? We'll just take a couple of minutes to introduce yourselves.
I love how that works. Interested to hear what everyone says they were recovering program directors.
There is life on the other side.
That was funny.
Like, all of a sudden you're like, by the time they graduate, they're like, you know,
That's why I love so much fun. And I get to do that twice.
Building new programs is the best.
I like building.
Yeah. Like creating.
So I'm a lot of times.
That's a very personal question.
I did have a very good opportunity. I did ask to work.
Also, they're not like a cube, but they chose, like, I don't know why they chose that. Just reflect sense of their, all the mountains are all in a cube. It's like look like cube. It's like connect with that. Exercise in class.
I need my house to near my horse. I get up on my
I didn't have a horse that's not out here. Climbing the cube actually because like.
Doing, I had a giant medicine, I traveled around the community hospitals. And I really enjoyed that. So that one, an ultrasound. And then I got turned around.
That's so scary for the flower.
Oh, you did the perspective from the
I'm not getting sun. This thing is about to crush.
Emergency medicine, all the things, a lot of things I sometimes down about it. Maybe some of the students that come through impresses me, but I want to inspire others to use other things to how you can make a difference with a relationship, even in a short amount of bit. And I also want them to work hard.
That's what I was waiting to hear.
They're all over the country and they're all I did some fishing we've had a lot going on, like academic stuff, it's like you go and you're like, oh, this is going to be.
Okay, we're going to wind this part up in the next couple of minutes. 2 more minutes-ish.
One of my nicknames in grammar school. I used to be research
All right, let's bring it on home.
You graduated I started here. Teaching range from patients to PA students to undergraduates.
We promise you're going to get more time to get to know each other.
Yep, but now we've broken the ice a little bit. We're going to be getting into some pretty cool conversations as the day goes on. So, how many of you are clinician educators? Your kind of clinical teaching tracks at your hospitals? How many of you are full-on research tenure style track? How many of you in a kind of a blended model? Okay, all right. So why are we teaching? Who benefits from the teaching that we do? Yeah, go ahead. Me. Oh, you. All right, so who else, ideally? Our patients. Ooh, like that, a second. Okay. And then who do we usually think of first? just kind of let's go. All right, so do you get a little anxiety when you see this picture? I do. Like, there's a little judgment there in the eyes of these trainees, right? So ideally the trainees benefit, and the patients, look at that happy patient, look at that, okay? Ideally they benefit, and ideally you benefit, right, exactly. But why don't we do it? Why don't we do more of it? We love it, we're here time. Pardon? Fatigue?
Some don't want to hear what you have to say.
Some resistance or perceived resistance, yeah? Acuity, interruptions. Intimidation. Tell me more about that.
So I had a couple of really brilliant residents working with me, and I'm like, Joe Schmo, run-of-the-mill, PR physician, whatnot. And I'm like, oh my gosh, this kid sits there and reads through journal articles like no one's business, and he knows all these things. What on earth am I going to teach him? Like, what can I possibly teach him? And so, yeah, sometimes attendings get intimidated by the residents that they have to work with because they're reading Rosens and they're doing all this top-notch, super stellar, cutting-edge stuff, and you're just you. So sometimes you get too big.
I love that, and that can really shut us down. That can really shut us down, and make it. If you ever had that hesitation, where you went into a shift with full-on anticipation to teach, and something happened, and you're like, yeah, maybe not, and you just focused, not today, and you just focused on the clinical care that day. Has that ever happened? It's happened to me. Right, depending, right, and we're going to address that. I'm glad you brought that up because we were going to talk about that explicitly today. All right, very good. All right, so some factors at play. We've talked about these, but what we often don't talk about is the fear factor. The fear factor for our trainees and the fear factor for us. We're going to talk about safe space. We're going to talk about growth mindset. We're going to talk about a lot of related issues.
I think in medical education we're very used to the idea of this fixed mindset versus the growth mindset. What often we forget is that you can't really have this idea of growth mindset if you're not kind to yourself. And so if you're constantly worried that maybe I don't have anything to teach my learner, my resident, or in that example, like my medical student may have read too much about this, or they have a PhD in something. Like we work in a place that sometimes it's a unicorn for us to have a medical student that graduates in 4 years, and so many of them will have extra training. And so figuring out what to teach them sometimes can be intimidating. And so the idea of growth mindset is not just for the learner, but also applies for us, that we can grow, we can also learn a little bit more, even if we think that our day is super full, or we don't have enough time to teach, or there's a lot of these things that are kind of whirling in our head. So I think just understanding that even like adding the word yet as a growth mindset, so when my resident, for instance, tells me like, yeah, I really don't know how to put in the central line. I was like, you don't know how to put in the central line yet. So adding the word yet in anything can open up this possibility that there's some room for them to grow, and for you as well.
Yeah, the importance of how you set the stage at the beginning of your shift or your work period is very important, right? So you can set up the expectation that all questions are acceptable, and there's going to be conversations about things where there's uncertainty, because we thrive in uncertainty in the emergency department. By simply saying something along the lines of, this is a safe space, I may not know the answers to this, but if I don't know the answers to this, we're going to look it up together. So everybody feels like they're part of the discussion. Like small signals like that can go a very, very long way.
And I Google stuff in front of them to let them know that it's totally okay to Google stuff, because I don't have to know everything. And I really, this gets to the idea of belongingness, because when you're constantly worried about trying to fit in, when you're constantly worried about trying to impress your learner, or vice versa, they are trying to impress us, right? Like, imagine all these years of getting into medical school and getting to residency. There's this expectation to have amazing grades, perfect A's, and so if you get that B in organic chemistry, like who cares now, but like for them at this moment in front of you when you're teaching them something, they still think that when you're giving them that feedback, they're like, crap, like I'm gonna get a B in organic chemistry again. And so this sense of belongingness, of normalizing, like I don't have to know everything, we don't have to know everything, however, we have to make some decisions, and here are ways that I have done it, and then they can probably learn from you in that sense, as opposed to trying to download all the things that you've learned into this one learner, because it's not feasible. And I struggled a lot with that, especially earlier on, especially when I work with, as emergency physicians, we don't get to work with so many of our residents for so much time, and as also a recovering APD, I felt the need to teach them everything every time I work with them, versus now I'm like, I just get to focus on one thing. Right? If I can win, I can like teach you one thing in the shift. That's a big win for me.
You know, I teach courses to a lot of people, and some of the courses that I teach, I have deans and chairs of departments learning how to coach, and it's quite remarkable the learned helplessness model that comes into these courses. Right? So these are people who run the institution. These are people who have the power to change the learning climate. And when they come into these courses, they have a sense that they can't change it, that it's fixed and unmovable. And one of the things we talk about is, you know what, if we can't do this, if we can't start to change the culture within our small spheres of influence, then nobody's going to be able to change it, right? So I want you to think about what you can do within your microsphere, however big or small, of influence to make it easier to kind of break down these barriers, okay? Because you can.
At the very least, when you're thinking about belongingness, just think of like that when you are an intern or whatever that role is that, of the learner that you have, just think of that senior resident or attending that you wish you had when you were in their shoes. And I think that will kind of set the tone for you and how you're going to be there for them.
So we've been talking a lot about safe space and learning climate. So that's one thing. That's one thing to consider. Another is knowing your audience. All right. So how many of you have off-service residents rotating through your EDs? Medical students, your own EM residents, okay? Random people that you never quite figured out who they were, okay? Each one of them has a completely different set of content that they need to learn, right? And unless you know what that is, no matter how well you teach and no matter how much you teach, it will not find its target. So we're going to talk a little bit here about the importance of diagnosing your learner, right? So that when you do teach, it finds its target, okay? Have you seen this? Kind of 2x2 tables are really helpful for me. They're simple enough that I can remember them, right? So across the top, we're talking about competence and incompetence within kind of the expertise mindset, kind of from novice to expert. And then we have unconscious and conscious down on the y-axis. And just like we did earlier, I want you to actually imagine a face of a person. You don't have to blurt out who they are. But I want you to imagine a face of a person that fits each one of these categories. Okay, you ready? All right, so unconsciously competent is a faculty member who sometimes has a little bit of a difficulty explaining how they figured something out so quickly, right? Unconsciously competent. A consciously competent resident who is really, really good at explaining their kind of thought process, if this, then that, to the medical students because they're super close to the med student, right? If I get the CT scan, it shows me this, I'm gonna do that, okay? Consciously competent. And then consciously incompetent, the very eager medical student who is terrified because they know that they don't know. But then we've got this one in the red who seems like they know everything because they're really confident.
But they really don't.
And they really don't, right? So everybody have a face of somebody in each one of these categories? Okay. How did you know who this was? It was a surgeon? How did you know?
Just insisted that I do something that was obviously stupid.
Okay, but the problem is that it can take a while to figure them out, right? Unless you're observing them in practice, unless you're doing some direct observation, unless you probe a little bit more in your questioning and your discussions of the case.
When you're signing the chart.
When you're signing the chart, right? Okay, and we're going to have in one of our in some of our other exercises later, we're going to look at some examples of some of these folks.
It's the people that come up in CCC when you realize it wasn't just a one-off bad day.
Right, when you realize it wasn't where there's a pattern, right? So, but you're often not going to know who they are unless you watch them in action, and there are some ways of doing that as well. So knowing your audience. So those are a couple of big concepts that is really important to just make sure that you consider as you teach because they're often not addressed and they make all the difference. And now we're going to pivot and get into procedural just-in-time training.
So imagine that unconsciously incompetent person who is trying to tell you that they've done 10 LPs. Have you ever had that? Because you probably had this case like, oh, worst headache of your life, and then I was like, all right, I guess we gotta do the LP, and then you ask the resident or the med student, how many LPs have you done? They're like, oh, many, 20, right? And you're like, this is impossible. You're like, this is your first day as a medical student in the emergency department. But maybe they have a different life, right? And so you give them the benefit of the doubt. We're gonna switch into just-in-time training, not only to teach them something, but also to diagnose how much teaching, how much guidance you're gonna be there for them. And also knowing just the different roles. and hopefully you can learn some tips here on your next clinical shift. So really the first one there is, so we're gonna use LP. The first one there is really understanding where you stand and who are the players in the room. So for me, I just have to conceptualize like, all right, so I will be behind you or I'll be in front of you. Actually, when we do LPs, I'm gonna be in front of the patient so I can like talk, depending on how comfortable the trainee is, so medicine or resident. If I know it's like their first time doing it, I'm gonna be right next to them. So, but knowing where you're gonna stand ahead of time is gonna be very important so that you can warn your learner, hey, I'm gonna be there right next to you. You can always just look up to me because the patient is looking at the other side, right? So these are some of the tricks that we're gonna share with you today. So before we do that, let's just pause and understand like what are some common issues that we've encountered when you are working with a resident, when you're doing an LP. So we'll, like, let's use this like a few moments to just amongst your table, just talk about some common things that have come up for you. We're gonna swap. We're gonna swap because now I need like a little bit more prompt.
I think the biggest thing is
I like the use of the first name versus the adult.
Yeah, Dave Matthew likes the opposite, so I'm going to bring it back to the first name versus the doctor. He thinks that like we're doctors, we should hear your name as doctor. You should be able to like continue doing your job, and if you call me by the first name, I should get nervous. But, yeah. I think so long as you establish what is good and what is bad.
I often do that in a shift at the beginning. Because, like we had a patient that kids start getting seizures like during assignment. PTG the other day. We ran in and we were getting hypoxic. The brand new pizza and chicken. Kind of getting the hypoxic. I said, is it okay if I take my hands and put them on my hands to teach you how to do this? And he's like,
I like that.
Changed it, and so, but from that point on,
Use that example. Use that example.
Okay.
All right, we're going to give you one more minute to wrap up. I know there's a lot of challenges that we encounter with LP.
Joey did this when you're the stage.
Is that right? I love it.
Of course he did.
All right, let's bring it back. So we want to be very clear that just-in-time teaching is not the time to teach your residents or medical students how to do the procedure for the first time. They should have an idea of what they're doing, if you're gonna give them some just-in-time training. Otherwise, it's gonna be very difficult to do that. And so what I'm saying is they should have simulations already. They should have done some sort of practice. This is not the first time that you open the box in front of them and for them to figure out what things are. And if that's the case, you can teach them how to do a lumbar puncture, but in a very different way. They're probably not gonna do the actual procedure. And knowing that ahead of time is gonna be very critical. So again, we have to prep the learner, right? We can't expect the learner to just all of a sudden know how to do like a lumbar puncture if they've never seen something like that before. This is also very different from the see one, do one, teach one model, because that's also very archaic, right? And so this is just, maybe they have done it many times before, but ask them like what, so again, make this learner-centered. What was it that gave you some trouble last time that you want to work on today? What was it last time that you learned that you wanted to try again this time to make sure that it gets solidified in your practice? So really, this is the step for that. So one way to do this in prepping up the learner is to clarify some roles. Who's doing the procedure? This is always awkward. Sarah and I have probably been in this situation. I can imagine you as well. When your resident's like, you stole that procedure from me. I was like, I didn't steal a procedure. This procedure needed to be done, and you were not doing so great at it, right? However, there's probably nicer ways of doing that or even establishing that. And so, for me, let's say it's a difficult airway, I tell them, all right, so this is what you're gonna do. You're gonna try this. And the next step is I'm gonna do this. Or in this case, we're gonna do a lumbar puncture. Oh, so this is your third time doing it? I love it. So you're gonna try, you're gonna do this approach, we're gonna talk through this, and if you have any difficulty, you look at me and we're gonna work on this together. Do you have any other suggestions about just like clarifying roles?
So sometimes you can decide that if there's going to be a red flag, being able to maintain the patient confidence through that communication can be very tricky, right? Because you don't necessarily want to call them out in front of the patient, but you want to be able to have a kind of a warning signal that things aren't going the way you anticipated, right? What have people done to try to kind of navigate that, just out of curiosity?
Safety words.
Safety words.
What are your safety words?
What are your safety words?
Look at those vitals.
It's probably going to be tachycardia for an LP. So what are the safety words that you'll use for a lumbar puncture?
Patient screaming in pain.
Yeah, but that's all of us going to notice that. Like, what is one thing that you can tell your learners so that they can be reassured that we got it, we will figure this out, and not freak out the patient? Because the last thing I want is like, oops, it's not a good safe word. Like, it's not a good, like, oh, yikes.
I'll say, we're going to reposition the needle.
Okay.
And so that's kind of my guide to the learner that something's not going right.
Yeah.
They're in the wrong space or something that's just kind of a, let's stop, or I'm going to assist you with this.
Yeah.
It's nice that the patient's facing away. Right?
Yeah.
It's also nice that I've started giving percent to all my LPs.
Yeah.
They don't really remember it, which is great.
I like the idea of let's reposition this, but I wonder if there's a way to say that so that the patient, if I was the patient not getting Merced, when I hear this, like, wait, why are you repositioning? Because then, right, so I heard earlier, like, people are worried about, like, evaluations. Not just evaluations from the patient, but also evaluations from the residents. And so how might we kind of save their face in this procedure?
I think let's give the patient a break.
Oh, all right.
Take a breath.
I was going to say, sometimes instead of saying you're doing it in an appropriate way, I say I find it helpful to.
I find it helpful.
I find it helpful.
Yeah.
And mask the instructions to the learner as I'm explaining to the patient.
Yes.
We're just going to be adjusting it a little bit. Here, we're just going to be going a little bit deeper. You might go a little bit deeper.
I love that.
Pressure.
Yeah. Here's another way that I've seen it work before. Oh, I can imagine that you're probably getting a different anatomy here, and that's okay. So we normalize to the patient. You know, like everybody has different anatomy. We will work with you so that we can do the best way approach that we can do here. So you're encountering something. All right, so I've seen this happen before. Here's another way that we will do it. Okay? These are great. So understanding the interactions in the room is going to be helpful. Are you folks familiar with needle epilepsy?
Needle?
Oh yeah. So your medical student is holding the needle and they're so nervous and you're doing this, right? And so then they can't. And then so what do you tell them? Stop shaking. They shake even more. So one thing that I would do is I will say, hey, so let's say she's the patient. I was like, all right, so we are gonna do this thing called the box breathing, and I'm gonna look at my resident. You're gonna do this with me, right? Because the patient was not really gonna see us. So all right, let's take a deep breath. Inhale over 4 seconds, and then hold your breath over 4 seconds, and then exhale over 4 seconds. And then hold your breath again over 4 seconds. That cube is coming back, and there's going to be spaced repetition here later on. And so that calms me down, because now I'm like worried about my resident who's about to do this procedure, and they're very nervous. Either they're nervous or they're hypercaffeinated, and I need them to not shake. And me calling that out is going to make them even more nervous. And so sometimes I don't even call that out. I just say like, all right, I talk to the patient, let's just slow things down a little bit. I can imagine this is very nerve-wracking.
Now, you tell the patient before we start, or before this can be kind of scary to a patient, so we're all going to calm down with.
That's right. So whatever you need to do to calm, there's also Versed, there's also Dilaudid, but there's also the box breathing. You can nebulize it, right? So some things to just talk about stopping. We were just talking about this.
Yeah, so there are things that are anticipated and there are things that are unanticipated, right? And so we've talked a little bit about the importance of having a little conversation ahead of time before you go into the room around your what ifs, right? If I start seeing this thing going sideways, this is what I'm gonna say. These are gonna be the safe words. This is how we're gonna recenter. And still things happen that you don't anticipate, yeah. Slightly different example, but you get the general idea. I come onto my shift about a week ago in the Peds ED, and during sign out, before I even get to know who all the people are in the room, a little kid starts seizing, right, during sign out. And so we go into the room, the outgoing team and the oncoming team, and this patient just got here, so the other attending hadn't even seen the patient yet, right? You know exactly what I'm talking about. Patient seizing. And the peds intern froze briefly, right? And then started trying to bag the patient, right? And we all know the bagging that happens by the smashing of the face and the occlusion of the airway, that kind of bagging, which everybody does. So I said, is it okay with you if I take your hands and I reposition you?
Is it okay with you?
Is it okay with you if I take your hands and reposition you? And he was like, yes, yes, you know, right? And so we did, right? We repositioned his hands, we bagged the patient up, the oxygen came right up really, really quickly. And I said, feel the way that reposition your hands like this, notice how that feels. Do you feel the seal? Do you feel how your hand is pushing on the mask? Yes, he's going to remember that for the rest of his life. And for the next several hours, he was completely and utterly teachable around everything, right? And so he leveled up that night. But it was because I had permission to actually put my hands on his hands. And I do that with ultrasound as well. I just have a kind of a moment at the beginning. If we're doing something procedural, is it okay if I get into your space and I adjust you, right? And when they say yes, that gives you a lot of opportunity, right? Because you can also stop them if they're about to do something dangerous.
I love LPs. LP is my favorite procedure. So one of the things that I do is to really set, I know you give me that look, it's like, really, I hate LPs. I love LPs. And so one of the things that I do at the very beginning is set up this cue. So Madeline, right? Madeline. We're gonna do this lumbar puncture together. And you're like, oh crap. And so you're gonna do great. And just know that if I say, Madeline, you continue what you're doing, because we talked about this already. But if I say, student Dr. Wolf, you stop. And whatever you do, you just pause and look at me. setting that signal, the patient has no idea, right? In their minds, it's like, all right, it's just Madeline or student Dr. Wolf. But for me and Madeline, we have a very clear conversation. If I call you by your student doctor or doctor, you pause. Whatever you do not proceed. And we'll just look, and then we'll talk either by looking, or we'll have a way of like, may I show you a different way of doing this? Or here's another way that I've seen that works. Other things that are helpful is like, if you know that the resident has done this procedure already, ask them, hey, what were the points that you struggled with last time? Oh, it's when I hit that spinous process. Like, what do you do next? And so you say that, all right, so when you are about to insert and you're hitting the spinous process, just pause. And then we'll walk through this together. What are other ways that you've seen done, or what have you done to address this? To kind of guide people in the moment so that it doesn't make the patient nervous. I've seen it one way. Here's another way that I've seen it, right? So that's another phrase that you can use. Do you just interrupt them? It's like, stop. Yeah, that one is probably, what's that, oh shit? Yeah, that was
not the right way to do it.
Probably not the right way to do it.
I think a lot of the times we focus on how we want to intervene on what they're doing because we think what they're doing may need some
ask them for their framing.
And I think actually a lot of the time, having been a resident not so long ago, the trainee may actually be the one that doesn't know what to do next, but is afraid to verbalize that in front of you or in front of the patient. And so I think I like to actually ask the resident for what their safe word is, or for what I should listen for when they are at a point where they don't feel comfortable, or they feel like they've done something maybe unsafe, or want to stop, or need a second, and how they're going to verbalize that to me without alarming the patient, without saying, oh shit, I think I just did blank, or I think I just broke sterility, or whatever.
Yeah, or when you see blood coming out, you're like, all right, I see blood coming out, this happens.
And so like if they, a lot of times it'll be if they ask me for a particular thing in the kit, that's their way of saying to me, hey, Andy, can you help me out here, or what do I do next? And then I step in and try to assist.
Yeah. So you've listed several pitfalls already. So what we're trying, this is for us getting meta again, we want you to just anticipate several of these pitfalls whenever you're about to teach a resident or students procedures. And so now you're actually doing it, right? Common problems that we've seen are like what? Hitting the bone early, blood coming out.
Offline,
yeah. Tell me more.
I've seen them go straight in the paraspinal musculature and just offline of the spine.
Sure.
Or the urinalysis.
Yeah, I tell the patient, I was like, this is gonna hurt. And it's actually very helpful if you tell me where it hurts. Of course it's gonna hurt. I'm gonna stick a needle in your back. If it doesn't hurt, I did something wrong. I normalize that to the patient ahead of the time, right? But if it hurts to your right or to the left, please let me know that, because then I can help redirect the needle. So I frame it in such a way that they are now part of the team. Like, you are helping me be successful with this.
And an occasional compliment to the trainee during the procedures.
Yeah.
It kind of
you're doing a great job.
Puts money in the bank.
Yeah. In some way, so I know that we're going to talk about this later on, but like before you even enter the room, if you have like a used kits or some references online that you love using, just use that ahead of time. So they're familiarized with it, right? And also, they're not as worried. Because the last thing you know is they go in there, they've never seen this, or they haven't done this in a long time, and then you expect certain things because you do it one way, and then remember the cube? Your cube is very different from their cube.
And you may need the teaser trailer as well, because it may have been a while since you did, say, the lateral canthotomy. So normalizing the quick review in advance and making that okay really gives you a lot of permission as well.
And you can also just improvise when you don't have like old kits. So for instance, one of the area that I highlight when they're doing the LP is they hit the spinous process, right? And you tell them, well, all right, so then just redirect cephalad. And so they just do this. And I tell them, like, and I use the pen. And it's like, you think you're easily moving the needle, but really you're causing a lot of trauma inside, so you have to pull almost out, redirect, and then advance. So I showed, so people are like nodding, right? So this is usually what happens. The reality is actually not this, because it's a very sturdy thing. The reality is more of, I'll use this. We think that we're entering the back, and we're moving the needle. So let's say this is the skin. The reality is we're like moving the things around, but it's not moving inside. And so that's why they're just hitting the same thing over and over. It's like, I'm giving up. And then you show them this outside. Hey, when you redirect the needle, just pull the needle almost out. And then I lost my clicker. Oh, it's over there. Any other tips? Fingers also use, like you can use that also to highlight if you can't find like a microphone to use to see. Oh, there you go. So I think what you're showing me is like parallel to the spinal sheath versus like perpendicular. Great, I love it, the spinous process. See, it works. But whatever you do, you ask them a lot of these things. This is a lot of like cognitive load for them. Just commit, all right, so we heard a lot of things, like what are you gonna do now? And you let them like commit to that. And then you do some backup stuff. Like if this doesn't work, then you go to another thing. So then this is like the important part also, which is let's prep the patient. You gotta be a little bit upbeat and positive about this. If you're gonna go in there, like you hate LPs and you go in there, it's like, we gotta do this thing, we're gonna stick a needle in your back, of course it's gonna hurt. They're not gonna be happy with this. And so you're like, all right, this is something that we do very commonly in the emergency department. You do the spiel, you talk to them about the consent. And then again, I do the box breathing with the patient, but looking at my resident. There's a lot of power when you just simply slow down the cadence of your speech. You may not necessarily have to do the box breathing, but by just walking them through the procedure the way that I'm speaking, it's a lot calmer versus, what are you doing? Do you feel the bone? Are you in yet? Like, that is very, very nerve-wracking for people. All right, so then now you're doing the procedure. We talked about altering the procedure earlier by using the first name versus the last name. That's helpful. People will remember their first name, and so when you tell them something positive, you're like, all right, you do this. And then when you call them out, student doctor, they're like, okay, that's the cue, I need to stop. What else? How else are we gonna redirect the procedure? You're getting spaced repetition here now. What other tips can you think of or you've tried? Again, in this patient, you might consider, or this should work, but another approach might be, right? So that's, again, non-threatening. Could you consider this approach? Is another way to phrase things.
At this point, the next step is?
Oh, at this point, the next step is? Yeah.
Move over.
I think in residency, I've heard a lot of attendings say, like, they'll prep the patient by just saying, like, they want to be really direct with me and like what they're saying and using like anatomical words, and they'll prep the patient by saying like, we're just going to talk shop quickly. Just to let them know that like everything that comes after that is like not necessarily that the procedure is going wrong.
Yeah.
But that we may be discussing things that like they don't necessarily understand, which I think can like kind of calm the patient down and not. They have the expectation that like they will not understand what's probably coming, and that's okay.
Yeah, I love that a lot. And in fact, I would double down on that and say something like, you probably don't know this one. When patients go in the operating room, this is actually a very common thing. Surgeons kind of talk to each other to think about the best approach because every anatomy is very different. In this case, you don't have Versed, and so you're very wide awake. And so you get to hear some of these things that we're talking about, again, focusing on you getting the right approach. So when you hear that, that's just us teaching because we want to make sure that we do this right. So again, including them in the conversation is going to be very helpful. Thank you for that.
And related to that, normalizing for the patient that it's common that multiple attempts have to be made in advance so they don't feel like something's going wrong when that happens.
Yeah.
And then your resident looks like a superstar if they get it on the first one.
what often happens when you're nervous, frustrated, angry, and you're doing a procedure like a lumbar puncture is that you don't even know how to articulate what the issue is or the cause or figuring out the solution. So knowing these three things, if you can fall back into, all right, so what is the issue? What do you think is causing this? We'll just allow the resident or the learner to step back a little bit to think through and to come up with the solutions themselves rather than you always kind of giving them the answer. I think that will also be a good learning opportunity for you because you might think that they're doing the wrong thing, but their framing is just a little off. But if you follow their framing, it actually makes perfect sense. I started laterally because from my vantage point, it's actually midline. Or the shoulder is rotated, and I had to enter a little bit on the side to compensate for that left shoulder being inward. So let's review the case. Let's think back of one of the things that some of the things that we've learned. What are the things that you're going to try when you do the lumbar puncture procedure with your learner next time?
Safe word.
Safe word, all right. Not ouch or oops.
I really like the teaching through education of the patient.
Yeah?
Nice.
What else?
I like the code word both ways.
Yeah.
I have a code word for trainee that things need to change and they can ask you for help by using code word.
Yeah. Code word, safe word. This is like, again, it's all about communication, right? Communicating ahead of time so that when you're in the moment, just know that this might happen. And if it does, then you're good to go. You at least have a way to work with it. What else?
I really liked what you guys mentioned, like when they're doing something right, or I guess necessarily maybe even doing something wrong. Kind of pointing out, like, notice how that feels. One of the things that we talked about as far as challenges is a lot of the procedures that we do are very feel-based. And so, like, as the attending, it's like, I know how things should feel, but it's really difficult to communicate, tactile sensations.
So tacit learning, adding some emotion, and giving them the actual steps and talking about it. This is what we're doing now. We're just being meta, right? And so after the lumbar puncture, you ask them, what did you learn today? What worked? What didn't work? Have them summarize the things, some of the struggles, and solidify that even better, right? Because I don't know when they're going to do the LP next. But at least in this moment, when you did it together, they've learned a few things from you, and they can really reinforce that. Go ahead.
A useful thing to do if you have time, too, is, okay, you did this, you struggled with that little part of it. Now, in your mind, I want you to go over doing that LP perfectly and not repeat that mistake you made this time, but imagine yourself doing it absolutely perfectly, the needle sliding in, hitting not too deep, but just when you pass that punk, have them visualize the whole thing and feel it with your hands.
I love, who does visualizations as a common practice? Yeah. I do this. Like, I walk into the emergency department, like when there's a code, I visualize how I'm gonna like run the code, the team. High performance teams do this. Olympians do this. Because then you know what the end goal is as opposed to just dealing with a lot of uncertainties and just navigating your way through it. If you can at least visualize, like, all right, and then you can't anticipate everything, but at least if you know like the beginning, the middle, and in the end, all the rest will just be like you kind of guiding them. That's a great idea. Visualizing in the end to reinforce what they've learned and also solidifying it.
Rather than rather than thinking about what went wrong, I want you to visualize yourself doing it perfectly.
I love it.
Even if you have to change the patient's anatomy in your mind.
I love that. What else?
Can I just add that I think you're talking post-procedure visualization?
Yes.
Yeah. Procedure.
Yeah. I think visualizing what
Pre.
I think visualizing what may go wrong so that you know how to anticipate and address it, particularly airway where there isn't a lot of room for failure. So knowing where you're going to go when you can't visualize what you thought you would see.
So we're splitting here, right? So there's the common practice of visualization before you do something, but I love applying visualization afterwards. Now that I've learned this, now that I've struggled a little bit, and struggle is a good thing here. If you didn't struggle, then like there's not a lot of learning. But now how do we leverage the struggle to then reinforce something so that next time you do it, all right, so This time around, I did this, and what I learned was that if I just readjust a little bit towards the umbilicus, then I was able to get the actual spot better, right?
The point is, though, not to practice or re-experience the
mistake,
but to practice the improvement version.
Yes. All right, so asking them what went well, what was difficult, what stood out as different versus the other times they'd done it. And then also asking them as part of reinforcing, like, what are you going to read on next? What are you going to reinforce next? You have them commit again to some of their learning. And this also goes back to you. Modeling, again, psychological safety and belongingness, right? What went well for me? I'll talk about this is what went well for me. Here's what I learned when we were doing this. I really did not anticipate that, like, I thought we were midline, but actually there's a lot of like tissues there and we were off. And here's what I would do next time. So sharing that is going to be helpful.
And if it doesn't go well, right, if something goes sideways, the importance of, depending on your own learning climate and how safe you feel in it, because every department's a little bit different, sharing some challenge you had when you were a trainee or a junior faculty member can be very empowering. Like when I had something similar happen to me, to normalize that. I remember when I had a procedural complication, when one of my mentors took me aside and said, and shared one of his. Suddenly I didn't feel like there was something wrong with me, right? So to whatever degree you are able to do that at your shop, it can be very, very empowering.
And also, it doesn't have to be that they have to be perfect the next time. Focus on the 1%. What's one thing that you're going to do differently next time? I think that phrase is going to be, or that question is a lot more powerful than like, what are you going to do next time? Just one thing. What's one thing? Just add that, again, from a growth mindset perspective. Here are some questions that you might consider. How might you use the approaches we just described in another procedure, right? So maybe it's not LP. Maybe it's the difficult airway. Maybe it's creating your teaching chalk talk. And so with that, thank you. And we're going to reinforce more things over the next few sessions.
Quick switch over.
We could do it in 3 hours.
All right, for those that would potentially like to have the handout that goes with this, there's a QR code up there. Just I'll give that a second for you to be able to download. It has a lot of the information that's on the slides anyway, but again, in our process of being true socialists, we are happy to share the slides as well. So we'll make sure that you have sort of ways to contact us to get that running. So we're going to run through several things during this session, sort of the idea of coaching versus feedback, and then is there really a way where we could meet in this kind of perfect middle and try to really weave things together in some ways. So most people have that downloaded now. Got the QR code. I see one less camera up. There we go. All right, so we have no conflicts within the bunch of us, except I write questions for the MBME on patient safety. Don't be mad at me about that. All right, so we thought we'd just do a really quick introduction here, and this idea of the spectrum of where learners potentially are and how it is that we can engage with them along the spectrum. So this is, as always, kind of an oversimplification, but if I was to say, if I'm on the end of things where I'm thinking about mentoring, consulting, I kind of put feedback into this kind of category that's sort of on your left.
the idea here is that sort of getting answers and directing is more appropriate to that. And generally to do that, you have to have some expertise in that area. So it's hard to be a consult, it's hard to give a consultant, or it's hard to give feedback if you don't have at least some expertise in there. If you go to the other end of the spectrum, you'd be thinking more about this idea of coaching. And there are theories for people in coaching that they'd say, you could know not one thing about baseball, but you could potentially go be a coach. I don't know if I completely agree with that, but again, the idea then of coaching is that you are sort of on a very different spectrum, and what you are trying to say is that the learner is the expert. They have this internal expertise that you're really going to try and draw on, and in many instances you are actually trying to get obstacles out of their way so that they can do the things that they already know how to do. So it's very much about this kind of questioning, and you do not really have to be the expert in that area at that point. Now, the challenge sometimes is to say, well, where are you on this? Early in my work as being a coach when I was in training, I did occasionally have somebody I was working with, and I'm like, wow, I feel like they're so disordered and disorganized in their approach. They're just sort of spinning, that I felt it was really difficult to say, I'm going to just keep asking you another question while you're spinning. And there are times, if you were to kind of look at the spectrum, whether it's you working with somebody on a professional basis as a coach, or whether or not you're saying this is a learner who I have to at least some point meet them where they are, which means I also have to kind of determine where do I think they are. So do I need to actually be more directive? Is that more appropriate? Am I more really in the feedback and telling? Because that's really where a learner is. This is also used sometimes as a leadership model. So when you're working as a leader, you don't always have to always remain in one sphere. You're trying to meet the moment, and this kind of applies to a lot of different situations, whether it's leadership, mentoring, teaching, is to try and define where do you think this person is, and then can you adapt a little bit to meet them where they're at. So we're going to start with a case. For those of you that were able to download it, the case is sitting there for you. And what we'd love for you to do is to kind of pair up at your tables with either 1 to 3 people, depending on whether or not you have even or odd numbers, and read through this case and just very quickly sort of how would you, approach this case. So we're just going to talk about this case for about 5 minutes. And just amongst yourself, what would you want to do with a resident or a medical student? We really focus mostly on residents here, but what would you want to do with this individual? Just meet up real quick, pair up, and talk to each other about how you would quickly approach this particular case.
almost never. And a lot of times, so there's some it's terrible when you're just seeing it's on
If you guys want to wrap up your discussions here, I want to hear from some of the groups on how this discussion went. Do any groups feel like they had some good thoughts on what to do with this second year resident?
Anybody have a case like this, like you've done this?
Go ahead.
I think one of the things we thought was like the first thing that you really need to do is kind of be like, why do you think you're getting this feedback? And like, can you give me specific examples of interactions that you've had? Because that's going to determine a lot, if they have some self-awareness of like, yeah, I don't really get along with the nurses versus being completely oblivious to it, your approach is going to be very different between those two.
Yeah, absolutely. So you've got a couple of great things in there. Of number one, this idea of sort of seek first to understand. What is the resident's perspective on this? Are they starting from, I had no idea about this, or are they starting from, yeah, like I want some help with this. I need your guidance as my mentor, because those are going to be two completely different conversations. And then also mentioning this idea of objectivity. What happened? What was perceived as demeaning? Was this direct feedback from the nurse who came and told you about it, or is this something you heard third hand from somebody whose brother might have been on shift with them 2 years ago and saw something like this? You want to try and get as many objective details as possible. So yeah, that's excellent. Other thoughts that people had on this? Go ahead.
This format's pretty hard for an incident like that, because at 6 months out, what happened 6 months ago was a nursing interaction. The resident will probably not remember any of that, considering how many shifts they do. So my hope for something like this would be that those evaluations come shortly after these interactions, so that you actually have more real-time tech feedback. In 6 months, it's really hard to ask them, hey, so how is it going? Or how are you perceiving these interactions if they don't necessarily recall them?
Yeah, so maybe there's a systems issue here, right? Maybe you don't have a robust assessment system that is getting you good data. Maybe faculty aren't feeling comfortable sharing some of this stuff, or residents aren't feeling comfortable sharing some of this stuff, or you don't have a mechanism of gathering feedback from the nurses when they're upset about this sort of thing. So absolutely, I think there are big sort of systems issues here as well. So we're going to start talking now about what I think you guys are most often asked to do about situations like this one that comes up. You see maybe a suboptimal interaction with the resident and nursing staff on shift, and it's time to give them some feedback. And and everybody's like, oh man, I got places to be after shift. I don't know. I'm not sure if I can really do this. I don't really have the language. Maybe I'll write something down later at the end of the month, maybe, and then I'm going to forget about it, and it's not going to happen. So this title of this section is Feedback is Hard, because it is hard. We're all asked to do this. We're all asked to be providing feedback all the time, but it's not easy. You know, we're supposed to be the trained educators, and it's really a challenging thing to accomplish. So to illustrate this point, we actually gathered some data from our faculty feedback cards that we asked them to fill out. And this is what our faculty had to say about increasing resident knowledge, build experience, build a solid foundation of knowledge, improve with experience and reading. And they actually like this idea of reading a whole lot. They wanted our residents to read a lot more. Keep reading to fill knowledge gaps. Keep reading, read, and read up, and then continue to read. Once you've started reading, just make sure you continue. And then they most importantly wanted to convey to the residents that whatever they were doing a great job at it. Great work, made good decisions. That's always a good thing for life in general. Great job today. You're doing great, and great shift, and even better, you're fun to work with. So these are trained faculty members. I promise you the faculty at my institution are not appreciably worse than the faculty members at your institution. And it just goes to show that this is, they're not trying to do a bad job here, but this is not great feedback, right? This is, it's easy to write. It's easy to write read more. I didn't have to put any thought into that whatsoever, but what's the resident gonna do with that? How are they gonna, take that to their next shift and do something different? So oftentimes, as faculty, we do kind of have some answers, some pointed areas where folks can improve. So let's flip it on its head now. What makes good feedback? What are some characteristics of this where we can really sort of do a good job, and some maybe best practices here. So number one, feedback should be expected. Tell the learners at the beginning of the shift you're going to give them feedback. Don't be that person who's kind of the executioner. You pull them aside at the end of the shift, they're like, oh crap, what did I do this time? It must have been something real bad, and they're coming at you from a place of fear, or they're backing away slowly. This also gives you an opportunity to ask them at the beginning of the shift kind of what they're working on, so that they can expect feedback on their patient presentations, their intubations, whatever it is that they're most focused on at the time. Don't be afraid to probe them a little more if they're giving you kind of a silly answer. If they say, oh, I want to work on my lateral canthotomies today. Yeah, me too, but probably not going to happen. So it gives you an opportunity to sort of focus them down in a sensible way. Feedback should also be limited. Have you ever met a resident who you could give feedback to all day? Probably a few of them, right? Unfortunately, we've all met some of those people. Don't do it. Resist the temptation. Find one thing that you really want them to focus on and give them feedback on that. Because chances are, if you give them feedback for 10 minutes, it may be gold. It may be the best feedback that you've ever given. But they're going to take one thing from that. And you don't want the nugget that you really want them to take home buried by a whole mountain of other stuff. So pick the piece that you think is the most important, most actionable piece of feedback and give them that. And on that note, your feedback should be actionable. People write things like, or say things like, you need to expand your knowledge base. You were kind of all over the place today. Oh, your social interactions with the patients or the nurses weren't very good. Well, what about that? How did that happen? In what way? What was deficient? What could be different next time? And importantly, what can change? So you really need to think back to individual patient interactions, individual interactions with nurses, individual things that you've seen in the department. Get down to as much nitty-gritty as you can. This is really hard, right? This requires a lot more thought and effort than being like, hey, you should read more. But this is what's going to actually actually make the difference for your learners and actually help them with this. One thing that I've seen that helps people be successful with this is to actually keep a note-taking device with you, whether that's a card or writing notes on your phone during the shift, because you're going to see this and you're going to note these things in real time, and then 500 other things are going to happen in the department. You're going to forget all about it by the end of shift. So if you're taking notes as you go, that can be a good way to get at this. Feedback should be frequent. It can't just be one-off. You should create a culture where you are a trusted person, where people are going to you and expecting feedback. That way, they are going to know how to contextualize your feedback. If you tell somebody, hey, you did a great job today with that lumbar puncture, that's going to mean a lot more to them than if you're giving that feedback to them every day and giving them opportunities to improve and grow, than if you're just saying, hey, you did a great job with that lumbar puncture, kind of out of the blue. Feedback should be private. Your learner is not going to be paying attention if they're constantly looking over their shoulder and thinking about the judgment of the other residents or the other medical students who are around them. This is the old praise in public, perfect in private, especially if you've got opportunities for growth, which I think you should. Give those to your learners in private so that they can really focus on what you're saying. And feedback should be timely. How many of you guys remember the growth areas for the resident that you worked with once last month? Remember what they were? You remember you're going to be able to give them some good, high-quality, objective feedback? No way, right? We've all gotten those evaluations from MedHub at the end of the month or new innovations, and you're like, I barely remember working with that person, let alone what was good about them. So you kind of write something down that's generic to check the box, and you move on with your day. That's not a good use of your time. It's certainly not a good use of the learner's time. Ideally, these interactions, these feedback conversations should be at the end of shift, maybe even during your shift. But sometimes, I grant, that doesn't happen, right? Everybody gets busy. There's a patient emergency, and you can't have that conversation at end of shift. Send them an email right after shift. Yeah, it's not quite as timely, but it's much better than waiting a couple weeks or waiting until the end of the month. Trying to give feedback to people as quickly as possible is key. Feedback should be labeled. If you ask learners about whether they're getting feedback, they'll all tell you, no, we're not doing it. But if you turn around and then ask the faculty members whether they're giving feedback, they say, yeah, we're giving feedback all the time. Where is that disconnect? What's going on? It's because the learners aren't understanding what the faculty are giving as feedback is feedback. So the important concept here is this idea of signposting. When you're giving feedback, you got to say, hey, this is feedback. I'm going to give you some feedback now on your patient presentation. Let me tell you a little bit about what I thought of that. You can also signpost this at the beginning of shift if you don't want to be constantly doing it throughout shift. Hey, my teaching style is I'm going to be giving you feedback as we go today. So when I tell you, my thoughts on the presentation, that's going to be me giving you feedback. You got to say the word so that people kind of key in and say, oh yeah, actually, Dr. So-and-so did a great job of giving me feedback today. So make sure you label what you're doing, and so you can get credit for your great work. Make sure your feedback is relevant. Ask the learner what they would want feedback on. This may open up a great area of discussion that you weren't planning on talking about, but is going to be a lot more impactful to the learner. I remember a great conversation that I had with a medical student. I said, hey, what are you working on today? What do you want to see? What do you want to do on your emergency medicine shift? And they gave me an answer that floored me. They said, I want to work with geriatric patients. I said, all right, we have those in the emergency department. I would never have thought about that, but sure, absolutely, you are going to see everybody 80 plus today. Great, awesome. I was able to create an excellent experience that was exactly what they were looking for. Would never have had any idea unless I had that conversation. Make sure your feedback is objective. It's really easy to kind of go based on reputation, especially for some of these folks who maybe don't have the best reputation, have had troubles in the department before. Hey, you've got to support what you're seeing with evidence from today's shift. So try not to rely on other people's interpretation, because your learner may be taking their feedback that they're getting to heart and really trying to make improvements. So if you can give them encouragement, hey, you're doing a great job making improvements with your interactions with nurses. Great, that's awesome. That's really going to help them stick to that behavior and continue to grow. Make sure your feedback is balanced. This is not the idea of the feedback sandwich. The feedback sandwich is dead. People can smell bull from a mile away. Don't be that person who is clearly just buttering them up in order to hit them real hard with some bad feedback. But if they mostly had a great shift and there are one or two little things that they should improve on, don't hammer them with their tiny little growth areas. Let them know that, hey, this was a great shift overall. Here are the things that I really thought you did well, and then here are a couple of things that could go better. And then finally, make sure your feedback is understood. Have you guys ever given feedback to somebody, said, hey, this was a great shift, here's one or two things I want you to do differently, and then all of a sudden it kind of looks like the tears are welling up in their eyes, and you're like, hey, what's going on? And they're like, oh, I heard you telling me that I'm a terrible doctor, and you're like, oh nope, that wasn't it. We gotta loop back. We gotta have this conversation a little bit longer, because not always are people getting exactly the message that we're trying to send. Not always does my cube look exactly like your cube. So I think just making sure, checking in with the learner at the end, that they really agree with you. They really are on board with making the kinds of changes that you want them to make. All right, so we got some more group exercise for you here. We're going to get you back in the groups to talk about a resident who has very limited differential diagnosis skills, kind of avoids making decisions. This resident is kind of trying to get people to tell them what to do and what they want. They just are trying to sort of pull things out of the attending, out of the senior resident, and they don't really have a lot to say themselves. So this is maybe a known concern. People are kind of aware of this, but you'd like to kind of give them some feedback about this and hopefully help them improve. So why don't you guys start chatting real quick about this one?
I'm Lauren. Great job.
I'll try and do better next time.
I'm digging, which I shouldn't be, because look, I have fun.
Figure out how you might do it more.
It was everything other than his knowledge
And you walked away and you're like, what just happened to
they're going to continue to be important for the behavior. And, you know, I think these sorts of things come up, we do sort of,
All right, let's come back to the group again. Again, it's like anybody had learners in this sort of role where they're just really, really, really talented at getting you to give them the answer. Like they kind of go just enough and then they go, but what do you want to do? And off you go because it's busy and you got places to be, and the next thing you know, you're like, wait, what just happened here? Anybody have some thoughts on sort of how you wanted to approach this, or how you have approached this particular person? And do you feel like this is a good case for, you know, is this where you think feedback is appropriate?
I mean, I was this resident. I can remember, like, distinctly as an intern, like, my plans always came out as questions. And it wasn't necessarily, like, totally for, like, lack of knowledge, more so as much as it was, like, lack of confidence in myself. And so I was, like, afraid to make a decision. And I can remember having, like, a couple shifts with my PD at the very beginning who basically just, like, kind of called it out and was like, I noticed that you present everything as a question and it comes off as if you're like unsure of yourself, but your plans are like pretty spot on. And then she like very kindly was like, I'm very comfortable with silence. And so I'm just gonna stare at you until you make a decision. And it was like kind of uncomfortable, but like we worked several shifts together and she like never bailed me out. And I think that was like a pretty pivotal like few shifts in like the beginning of my training that really like started the breaking of that habit for me of just like calling it out and just being like, we're just gonna all be uncomfortable here until you, it worked for me. I don't know if that would work for everybody, but.
Well, you know, feedback that was direct, specific, and then, you know, in the end made it actionable by her behaviors thereafter, which is kind of interesting. Sarah, you were talking about like a cultural norm.
Yeah, so I was working with a resident a few years ago that had this exact concern kind of in their feedback. And when I met with him to kind of get a better sense of his context, it wasn't a knowledge issue at all. When I asked him about differential diagnosis of chest pain, abdominal pain, he could spout off the litany, so clearly had the knowledge base. But what it was cultural norms, the way he was raised in his culture, was that he was exceedingly deferential to the attending, very, very kind and humble to a fault in public, right? And so it was we get into this concept in coaching all the time around intent and impact, right? His intention was to convey respect. The impact of his actions in this context was not landing that way, right? And so, so we actually have an entire course where we talk about coaching across difference, and trying to, now that we have an increasingly diverse workforce, this is becoming a huge issue around professionalism concerns, quote unquote, and insight issues, quote unquote, which aren't those at all. It's really just a kind of a disconnect with how things are being perceived and shared definitions.
So really kind of, but again, I think, these are opportunities for reasonably, you can diagnose the issue, you can offer some ideas. I think I think you also have to realize what you're bringing to this. Control your own urge to give them the answer. That's up to you. And the other thing is again, how much do we make it very safe for people to be wrong? What is our style in that moment to make it very, very comfortable for people to, this is a great opportunity to throw some things out here and then we can talk about them. So again, we really do have to be aware of our own behaviors and what it is that we help facilitate for some people. So thank you for that, and thanks for some of this. So kind of move to the other end of this spectrum and into just kind of straight on coaching. I always have to confess that coaching and working in coaching for me has been a lot more, it started out about me, in part because I'm an ER doctor and I'm like, you come to me with a problem and I have a solution, and I like it very much because it's my solution, and off you go, off with the next thing. And coaching for me both was, the way of trying to be better about silencing my own busy mind and taking the time to make sure that I could hear and I could listen. And then, the idea, I think we've been very good as ER docs about telling patients what to do, right? I'm going to tell you what to do. And so how's that working out for us? The idea that we impose what we want people to do doesn't always ensure, and really I think more and more we recognize it does not get us what we want. And so the idea then within coaching is just this it fundamentally is the belief that the person that you are working with has the skills to, really answer their own questions. Your opportunity is to try help understand what is getting in the way of the things that might otherwise seem inanely obvious. If you're kind of working with somebody and you kind of say, well, what else could you do with this interaction and engagement with a person that might make this better? And they just sort of go on, and in your head you're like, pick up the phone and make a call. But the point is not that that's the easy answer, because it certainly seems like the most obvious thing. Call this person, have a discussion. The most interesting thing is what is getting in the way of them calling this person. And that's really much more the why here. And so you're trying to help people sort of understand what inhibits their own performance, but also come forward with their own ideas, because you get them to embrace what they have brought forward better than perhaps telling them. There's a lot of coaching programs out there. Sorry, I went just a tiny bit better. We'll talk a little bit about the T-GROW model, but it is built around this idea here where in the center is you have your individual and you are trying to work with them, and you foundationally are trying to say, I'm going to evoke awareness. We're trying to be a partner here, not somebody that's going to tell you what to do. There are different kind of frameworks. GROW is most common. We added the T because occasionally when you start your engagement with somebody, you forget to ask them what they want to talk about. And off you go. But the idea is, what is it that they want to bring? Now, with a learner, you may have to kind of facilitate this a little bit, is that, what do you want to talk about in terms of your shift today? Or if it's more of a sit down for a little bit better, what are some of the things that are on your mind? What occupies your mind and what do you want to look at in terms of trying to work on something? Then there's the goal. What would success look like for them? You have to spend a little time learning their reality and recognize as a coach, it's their reality. Not necessarily, and this is why sometimes you're not the expert in this. You could even be a little bit removed from this individual so that you don't try to add context. Yes, you're going to get their side of the story. But, in so many instances, that is the side of the story, right? Their perception becomes their reality. You got to understand it when you're working with them. There's a lot of things here for you, right? This is, what options do you have? What options do you see moving forward? You can also say, what are your opportunities? What opportunities do you have to move forward? And because I'm a pessimist, I'm always like, what obstacles do you see? But in each case, there's a lot that you can pull out in the O. And you can spend a lot of time there. And then ultimately, as you begin to sort of weave together what you think are beginning to be some steps that they might want to commit to, it is like every engagement at the end, what will you do when you leave here today? What do you want to commit to? What is the strength of that commitment? So there are different models that you can use to this. This is sort of the International Coaching Foundation's model, and it's, you know, it's simple enough that I can sort of stick with it and manage it and remember it, which is my kind of key thing. So obviously people go to courses for about a week to learn coaching, and then they go through a whole process to get a certification. So this would be your 5-minute, you know, college education on coaching. Conceptually, though, this is really pretty easy. This is really much more about listening, slowing your own sense back, not giving the answers, helping them find their own questions that they want to answer. All right, so again, here's a case. In whether or not you return to your partnership or whatever, some people are off to the group table thing, but point is good discussion is what matters. This one's a little bit more different. I will tell you that I put this case on here because I have had this, you know, this scenario in some version, and just again, interested in if you were thinking about what approach might you use based on, and understand we've now talked about both feedback, we've also talked about sort of coaching, and now it's really about, of these sort of things that we've just talked about, what would you want to do? We'll take about 5 minutes for that.
Personality disorder is hard to remediate.
I feel like it's worse right now because part of like the first that year we have that
And so she's going down to kind of the minimum non-clinical time. And getting other people involved to get the slack, which frankly should have already happened. Now she's great. And so she was complaining about something. She was sharing I have a head doc and complains that he doesn't feel like he's part of the exam. Let him share, give him the response. And she was part of the discussion, part of the residency program. And now she's saying, well, I don't think we should do it. Like, I'm not even. So our vice chair for education just responded to her about it. So I'm just watching.
One of them said that they've been not good fit for work though, not good fit for neuro.
They don't succeed.
The issues were definitely one of them falls in that category.
That's just like one thing. I'm sure there'll be more as I'm sitting here today.
Yeah.
To go back to the now there's medicine.
Right, we wanted to believe the outside case, but yeah,
I really struggle.
Yeah, in my mind, it's a good thing that there are Oh my god, that was a nightmare. Every and nobody is happy either way, right? If you're activated every time, like, staffing is good, then people are like, oh my god, I can't believe you're calling us in. And then if you don't, if you're like, okay, like we're gonna leave people at home, then you're like, this staffing is terrible. It's not enough people here. So like, yeah. Yeah. Or people, they figured out how to do the system. Like, oh, like, I'll activate for this shift that I don't like working, and like, you know,
I'm curious to what extent maybe you want the individual loss of try, okay, get your back.
if there's a like that Fridays are when there's a fifth when they get in this one. Except for the whenever it's a normal routine school, which is 7. They come in at 5 and take 7. Just don't carry with the switch.
All right, let's come back from that one. Let's see if anybody have any ways that you want to approach this one? Yep, you've all had this one. Any ideas, again, about the ways to approach this? And do you feel like, you know, is this a coaching moment? Is this a feedback moment? It's hard. I mean, I think again, context does matter, right? Is this somebody that you feel like this is, you know, this has been a problem and a repeated problem? Maybe that's a little bit more of a direct feedback versus maybe this really is to the best of your knowledge, a solid individual who, you know, again, then it's sort of the why, you know, and again, I've had somebody says, well, I thought it was the other patient. You're like, really? I'm really sort of most interested in, you know, why would you feel that I don't know isn't, you know, an opportunity for you when I ask you a question? Because, you know, I think there's a couple things that are incredibly useful for emergency medicine physicians. One is called thank you. And the other one, which is a gift to patients, is called I don't know. All the way across, you know, yeah, a consultant can come down and ask me something. I'm like, I don't know. But they're very helpful. They're helpful for, and are we making it safe enough for people to say, I don't know? Any other thoughts? Pearls of wisdom? Please.
For me, this is kind of a non-starter. Someone lied. And, you know, lying about something that involves a patient's health is not acceptable. But I also set that tone at the beginning when people join my team, whether it was a resident when I was a program director or a faculty member. Like, just be honest. We'll work through whatever the implications of that are, but you gotta be honest.
Yeah.
And I don't know, I think we take a vow as, you know, physicians, you know, and this just doesn't sit right with me.
Yeah, I mean, trust is, you know, what we say is that trust is earned in sips and lost in buckets. So obviously it's an incredibly important thing.
Oh, may I also point out that maybe it might be reflective of the teacher as to why they're lying in the first place. Like maybe they're nervous of you or you've scared them before, and maybe being introspective about that might be helpful too.
It is very much kind of, you know, what we've, you know, said a little bit here is that, you know, this isn't just about the learner. This really is about us and the tone we set, how we give feedback, how we make it safe to be wrong. We can't learn without being wrong. And if we make it really unsafe, we grow up, there's multiple choice tests, there's always a right answer, and it makes it very, very difficult as we move through this to suddenly say, I don't know, or I'm wrong. And that I think it really weaves in, and as clinicians, who here feels if you get that remember the patient discussion, should it really be such a gut-wrenching feeling? And yet it is. So I'll turn it over to you.
All right. Where's the clicker?
Anybody have a clicker?
The clicker. Ah. If I was only a little bit taller, I would have been able to see that. All right, so we've talked about feedback, and we've talked about coaching, and now what I'm going to try to do is kind of weave an intermediate space in between these two. I'm actually a professional coach, and one of the things that we're doing at Stanford is we've built an entire coaching program to teach educators how to coach and integrate coaching into the work that they do. And this is an example of how we developed a medical student coaching program that created an environment in which we trained a group of faculty in how to coach. We paired them with medical students, and this was during COVID, because we were very worried about the medical students during COVID because they were losing their opportunities to rotate on their OA electives. They were very, very isolated. They lost about 6 months of clinical training, and so they were feeling very underprepared for their residencies. And so we created a just-in-time coaching program. And what we found was in this program that all the students were comfortable that the coaching discussions would not be used in their formal assessments. They felt that they could be candid in discussing their clinical growth, so they felt that they could discuss their weaknesses with faculty coaches, and that it would not be used against them. All the students indicated the coaching program increased their professional identity formation and helped them align their own core values with those of the specialty. And all the students enhanced their clinical abilities. And here, very important, all the faculty who opted into this completely volunteer coaching program during COVID felt that their professional fulfillment was enhanced through being a coach, right? So this was an all-volunteer program, cost nothing, right? And had tremendous impacts. The reason I include this is because sometimes we think that, is it possible for us to get into kind of these coaching roles with our students and have them actually be candid and honest with us? It's actually very, very easy to do it. You just have to signpost it, okay? And there was a 2-hour workshop that we trained people up in. So as far as coach approach to feedback, there's 2 really important frameworks that you should be familiar with as educators. Both of these are being pushed by the ACGME. You're going to learn more about them in various other courses that you take, but I just want to give you a little bit of an introduction because they relate to many of the things that we've been talking about today. The first is the R2C2 multi-source feedback approach. Have you guys heard of R2C2? R2C2 is stands for, the first R stands for building relationship or rapport. The second R stands for reaction. The first C stands for content. And the fourth C stands for coaching. Okay. And so what this is a feedback tool designed to help you as a faculty member debrief with a resident around difficult feedback that they have received. So this would be a very common conversation for you to have as a clerkship director or as an APD or as a residency coach when the resident has just gotten, basically is drinking from a fire hose around all their CCC feedback, and they're trying to kind of sort out the signal versus the noise, right? You are not the source of the feedback. You are their partner in helping them debrief the feedback. Okay, you with me? Okay, so they've just gotten this report, and you're sitting with them. And this is an approach that you can take that's actually scripted out and very, very helpful. I use this all the time in sorting out kind of what steps they can take to be successful in this program, all right? And it's a coaching approach to feedback. The other is a coaching approach that you can do in real time in the emergency department when you are the source of the feedback in a clinical situation, right? So this really relates back to in the just-in-time training that we were talking about, how you're going to give feedback in the moment with your trainee. And this is called the ADAPT model. And I'm going to do kind of a deeper dive into both. So one is where you're debriefing and you're helping them kind of understand context from someone else's perspective, and the other is when you're the source. Are we good? Okay. So in your handout, I put links to all of these references, okay? If this is something that you think would be helpful to your faculty, both of these sets have a full-on faculty development slide deck in them so that you can actually take your faculty through this. The ADAPT model also has a learner development module in it, so you can train all your residents in the approach as well. So everybody's on the same page and the expectations are clear, all right, which is dynamite. We've been talking about the importance of relationship and safe space. So when we talk about the rapport building, the context and the safe space that you develop as you bring a coaching style forward is one of trust, all right? So the first R is around building that relationship and building that trust. When you have that trust and you have that relationship, they can then have their reaction. Have any of you ever gotten feedback that kind of made you angry? All right? Any of you kind of get gripped in the freeze when you read it because the person giving it to you was your boss and you didn't feel like you could actually have a reaction and you had to just shut down? Has that ever happened to you? Okay, I'm going to normalize this. Has happened to me. When I talk to my colleagues, it's happened to every single one of them, right? So when you bring a coach style forward in these conversations, you have the trust, you let them have their reaction, their real reaction. They can be angry, they can be upset, they can yell, they can question, they can get belligerent. That's okay, all right, because you're in a coach space. Once they vent that out and you hear their context, all right, because you'll hear a lot of their context in this discussion, then you can partner with them and explore the content in the feedback kind of set, right? What in this? Yeah, I hear you. This maybe wasn't valid for right now. We're not going to focus on this right now. What is some content in here that we can focus on that does align with your self-image? Let's start with that. All right, what can you get behind? What's something in here that's a kernel of utility, right? And then you coach around that, and as you get deeper into this kind of discussion, then you can start going into some of the other spaces that they're more resistant to because you've built that trust, right? You can't launch right into the hardest part right at the beginning, right? Because they have to trust you, right? But you can, right? So this is R2C2. So these are some questions. These are actually some scripts that you can use when you're new to this. Okay, so in building the rapport and relationship, asking a question like, how's the rotation gone for you? Tell me about what you enjoyed, what challenged you. How do you think you're doing? What are some of the strengths and opportunities to improve? Tell me about your assessment and feedback experiences. What's been useful to you? What hasn't been, right? So that you can see and frame the discussion from a perspective that's going to be more likely to land. A lot of this is diagnosing your learner, like we talked about at the beginning. Okay. Then letting them explore their reactions, all right? For the resident to feel understood, this is validation 101, all right? What are your initial reactions? It's often going to be very, very clear. You may not even need to ask a question because this may just happen organically, okay? How did these data compare with how you think you were doing? Are there any surprises? It's a very effective question. And this is a very, very impactful statement. It's very hard to hear feedback that disconfirms how we see ourselves, right? So once they feel heard, they are more ready to get into the content. So This stage is for them to actually figure out what opportunity exists for them to level up in your program. All right, so this is the teeth. Was there anything in the report that didn't make sense to you? Anything struck you as something to focus on? Right, so again, we're drinking from a fire hose often when we get these CCC reports. Give them the power to choose what they do first. And then coaching for performance change. Okay, out of all of this that we just discussed, what are 1 or 2 priorities? What would be your goal? What might get in the way, right? So coaching only works because there's accountability built in. All right, so really kind of moving people from an external focus of control to an internal one. My data to use my way. All right, now the pivot. Again, this is an introduction to the ADAPT framework. You are now in the emergency department with your trainee. Bringing a coach approach to kind of real-time clinical observations, really, really impactful. At the beginning of your shift, and I use this all the time, at the beginning of your shift, saying, you know, there's a million things to learn in the emergency department, okay? If I could come in and watch you do one thing today, and then give you feedback on that one thing, what would it be? Oh, actually, I'd like to get better at my trauma resuscitations, right? So you're gonna have to be in there anyway. So now you have permission to give them all kinds of feedback about the trauma resuscitation, and they don't feel like they're drinking from a fire hose, right? So this is the most important piece, is here at the beginning, is in the conversation about what it is that they want you to give them feedback on today. All right. Once you do this a few times, then you start getting permission to give them feedback on things that they don't want to hear about. But you do this as money in the bank first, okay? So they perform the trauma assessment. You ask them, how did that go? They'll often be much harder on themselves than you would ever have been, all right? You discuss. Then you ask again for what did you get around to thinking you're going to do next from that discussion, and then you plan together next steps, right? So this I use all the time, how to adapt. And this is a resource, and this has been studied, and the residents and fellows loved it, right? So this is highly acceptable and intuitive for the residents and the faculty. All right, so again, ask question number 1, how do you think that went? Have a conversation about it, limit it to 1 or 2 observations. Any questions about what we just talked about, and then a check back. All right. So now let's return to the first case. All right, this is, you're the faculty of a second-year resident who just got this tough feedback, all right? Choose one of these mechanisms or a combination of the above, and maybe approach it a slightly different way than you did initially, and just kind of discuss amongst yourselves how you might approach it differently. Yeah, we're good. Because it just evaporates in this air. It's just gone. That's a really good way to.
We've changed a lot of sort of language and expressions and like the way that we do like being as strong as CCC you're not getting it. What people's generation you know, we sort of they're coming by the consensus of the faculty has it is tough for the city needs to be able to all it takes is one.
Giving everybody learning, personally learning how to outset to normalize this. This one person just and this was like pre-relocation. It's like prospective, proactive.
All right, why don't we kind of bring it back again? So we want to get you to a break here because you are adult learners and you've already been sitting too long. Any thoughts in just very quickly, ideas, thoughts about, you know, the way you might have initially thought of this and the way you might be thinking of it now? Any evolution in thinking or just like, oh, I might try something a little differently? Does anybody feel safe to share that?
I feel like giving people space to express themselves before you like get into the like actual or procedural stuff is like pretty important because it's like you're trying to build a foundation on something that's not stable yet. So that's something I would do, but I'm just so.
Well, and thank you for sharing that, because I do think that sometimes we have sort of our own mental model of what we want for them, and it may not fit. And I think people will do what you tell them to do for as long as they think they have to. It doesn't always sort of let them evolve into their most successful person. And it's also, people are different. I was telling the table that I've worked with somebody who, I mean, he just seemed to not be able to see nonverbal cues. He just could not see them. He's a nice man, very well-intended, very sweet, but he would just sort of walk in and you could just watch from a distance. Like he'd blunder in, he'd interrupt the nurse and the patient. They'd look at him. And then, you know, the nurse would wander off because now she's irritated, and the patient would kind of start smiling and then would kind of go like this, and, and suddenly, you know, she's like, it was just, you could see from a distance what he could not. It's a very different person to try and get them to success because you know what he wanted to be, and he could not do it without that. All right, so we're going to take you a break. The one thing I would like all of you to do is, if you know, for your 30 seconds, is there something that you want to take home that you want to try and do a little bit differently? And as we do in coaching, will you do it? How committed are you to doing that? And we'll see you after a break of
15 minutes. So see you back at 10:30.
Look at us go.
Hey, Sal, who's up next? And I'll pull it up. Is that you and your balloons?
What did you do for that dog?
The one who had the rectal exam?
No, the one who...
Oh, so sort of blind too? In some ways, it was first of all saying, you know, is to recognize, like, you're not picking up on this. And I don't know, so it was sort of, what are you focusing on in that moment? You know, I think sometimes you can get so in your head, the differential diagnosis take care of their problem, that you're forgetting to see. But for him, I think it was also, he just didn't quite do it. And so, you know, if you've ever seen the pediatric thing for pain, instead of what's your pain from 1 to 10, you show this little pediatric thing, is the baby smiling or is it, you know, crying out? It was sort of like, see these faces here? It was like, you know, let's walk through what this face means. And what to, you know, and it was just sort of, I'm going to train you to try to be more aware of what people are trying to tell you without speaking. And we just kind of worked on that a little bit, and also said, get out of your head for a minute, pause for a few minutes, look at what somebody's doing with you. So it was really trying to just train a little bit to, you know, it's like if you're autistic, you see things differently. If you, you know, have a little bit of a learning disability, you know, it just seemed to be he couldn't quite see. Are you really?
And I do, at 60, I got the diagnosis of autism, they call it Asperger's.
Yeah.
And it clarifies so many things, and I never had a coach who took the time to do that.
Yeah, it's, you know, it's like people have this kind of just range, and some people just have this situational awareness. You're like, you got eyes in the back of your head. They'll have some other thing that they don't do as well. But for this, it was, you know, people will try to speak to you on many levels, and they will do it with their mouth. They will do it with tears. He could pick up on that, you know, somebody very emotionally upset. But yeah, but a lot of the other just subtle things about watching those facial expressions, and then just sort of asking, are you upset? Now they'll be able to say to you, what's, you know, you seem upset. How can I help you? Or am I doing something? Now they can verbally tell you, well, you're interrupting me. I can't finish any sentence. You ask a question, you don't let me finish. And it just becomes opportunities to just kind of quiet and slow things down a little bit, so that you can pick up what you're missing. That worked well for him. Everybody's a little bit different, but that seemed to be a little bit helpful for him.
Thank you, Robin.
No, happy to do that.
Intermittently for 30 years.
Yes, I think we have. I think we have. It's the fun of this meeting is that you just kind of keep. It's a small world.
I'm officially retired.
Oh, good for you.
Except I'm still working in the African nation.
I got that sense. Sounds beautiful and very special, I'm sure.
To walk out of the ER and see that.
Yeah.
I mean, literally, I just opened the door and there it is.
Yeah. Sounds lovely. Sounds lovely.
It is beautiful.
Yeah.
But it's also, you know, when the wind is blowing and there's blowing snow and the helicopter can't fly.
Right.
You have one ambulance in 50 miles in any direction.
It's not as nice.
You've got a sucking chest wound.
Yeah. Yeah, you know, early in my career, I was in the military, and so you really had a sense that, you know, you would do anything, anywhere, and it just didn't matter. And then you start working in an academic center, and you realize everything is in the hospital behind you, and, you know, the best care is to bring down a consultant. Bit by bit, you realize, like, yeah, I've lost a lot of that skill set.
I started out in remote rural, spent years in academia, and now I'm back in remote rural. I'm bringing over 40 years of experience with me, and it's great.
Oh, I'll bet. That sounds really, really rewarding. Sure.
I'm family medicine trained, which was in the era of no attendance. Almost no people unless they were treating about and teaching about humiliation.
Yes.
But I got my mother did emergency medicine. I was an academician. I worked in inner cities and lots of places. So anyway, I get this new job at the MHPE.
Okay.
Family practitioner or an emergency physician because they're desperate for docs.
Okay.
And I'm supposed to work at 9 a.m. the second shift. We have an 7 a.m. person, 9 person, and 2 person, as well as a night person. So I'm getting ready to go, and I get a phone call. Can you come to the emergency department immediately? Dr. So-and-so. Okay. I guess my reputation precedes me. So I go in there, she says, I'm not comfortable putting in a chest tube. Can you do that? I'm like, yes, I can do that. 5 minutes later, the guy's got a chest tube.
Have a job.
What do you have to like for me to do? No,
Unless you don't want to. Unless you don't want to.
Down, start doing that work, and about 30 minutes later, I couldn't enter it.
Like my oldest took
First pass.
5 hours.
I didn't pass the difficult It made higher education.
It does help. It does help, yeah. Well,
Now when I screw up, people remember that now.
oh, yeah. I would bet. Well, thank you for that. I appreciate I think you should be proud of yourself. Just going to try and get this set up for who I think is next. Oh, my gosh. That's delightful. It's good to see you again.
Thank you for teaching me.
Oh.
I still mess up with the subtle cues, although I've over the years I've learned to see faces, but the problem is I can't always interpret them.
Yes.
Seeing is the first thing, but interpretation is the other thing, and sometimes it's culturally dependent.
Oh, very much so. I mean, I think, even people who would normally say, I think I'm pretty good at picking up those clues, you'll still, don't get too comfortable with that. You get too comfortable with it and you're going to, misinterpret. And again, it may be cultural. It may be that just somebody is sending something that you interpret incorrectly. So don't ever get too comfortable with it.
Navajo, for example, would be pointing like that instead of with their fingers.
Right, and you're like, what's that?
That I learned, but I had to learn that consciously.
Sure.
So I spent a lot of my time trying to learn multicultural body speech to go along with multilingual.
That's pretty bad. That takes a lot. That takes a lot. Well, I'm going to go set this up here.
I try to do it all It's part of your job.
How much of this stuff is sort of modifiable? It's not quite growth mindset, but like, clearly some stuff like what we described could be modifiable. We've got a recipe now. Same thing that you're talking about, our use and we try all these things. Maybe this is some fixed concept. Like his thing are all like, this I don't feel comfortable inside of like slow and gravity to that. And I'm gonna find the practice environment for myself. And you're like, from a coaching perspective, like you're doing just fine. Like you are succeeding at the one that you're setting. It may not be the goal set for you, like right?
Yes, training, you got to be all in. Yeah, you have to pay attention.
It doesn't feel good inside, but it's
Yeah, exactly. Just say it.
Cross fingers.
Defending Robbins.
Yeah.
People did sign up, or they are
I feel like some students are kind of given permission to be able to do so. So the questions are very hard to touch on.
Yeah, the series of briefly talked about like
I think it might make more sense to go out.
Oh yeah,
so I guess that doesn't matter.
And then Jazmyn and I will
That feels good to them, better.
Sally, you probably would, because I was going to have to think for after mine. Okay. Then they can incorporate.
So, Sally is nice.
Do you remember his early podcast he made? Everyone never gets steroids?
I saw Steve, and he was talking about which of those techniques they're using. Just different ones. I didn't really touch on, they would like to talk about things that they would like.
Yeah, well,
Hey Mary, where are your slides?
my notes in there.
Yeah. We should probably put our heads together and make sure we're on the same.
Oh, there we go. That's it. Okay, yeah. Got it. So,
Okay,
yeah, those are mine. So, excuse me.
Has our director of coaching from UW reached out to you, Sim Man? What is your investment in SAEM? Because I showed it to you guys. She basically wants to be you when she grows up. She is like, let's get her residency program around, like wants to expand it to faculty. Yeah, so that was where they were going to meet someone who was going to notes. I think it would be an amazing resource for her. Yeah. I feel like I exhausted it.
It's on the Google Doc sheet.
I'm sure it's a good
I'm lost in the sea of Google Docs at all times.
They're using section.
207.
Just debrief.
249.
965.
And then they can practice
All right, everybody, we're going to go ahead and get started. If everybody wants to take their seat. Can you hear me okay? Yes. Wonderful. So we are going to move into the second phase of the boot camp, where we're really going to focus on clinical teaching in the emergency department. We want to give you guys ideas. We want to hear and let you hear from one another about the techniques that you're using and really give you practical strategies that you can put in your teaching toolbox. So the way I like to think about this is really considering the anatomy of an ED shift. When you really want to work on your teaching, it's helpful just to kind of map it out. Where are the teaching opportunities happening? And thinking about them in these various categories. So I like to conceptualize it as before shift. That's kind of the preparatory work that you're doing. The beginning of the shift, where you're kind of setting the tone with your learners. Mid-shift, where you're actually doing the work of seeing patients and utilizing those teaching opportunities. And then sign out, where there's actually opportunity to do teaching with the off-going team and the oncoming team. And then after shift, that's where that feedback and debriefing and reflection piece comes into play. So even before you walk into the emergency department, that teaching, should be entering your mind. There's two types of emergency physicians. There's those of us that look at the schedule beforehand to see who we're working with, and there's those of us that just show up. I like to look at the schedule beforehand because it's helpful just to think about, is this a learner? Is this a resident that I've worked with before? Is this somebody I've never worked with? The last time we worked together, what were some gaps that I noticed? What were their strengths? How can I incorporate this into my teaching and coaching and feedback on shift this next time around? And then I think it's important for us to display that growth mindset just as we push our learners to do. And if you're somebody who really wants to devote effort to developing in your teaching, which I assume you all are because you're here, thinking about yourself as well. What is a strategy that you would like to incorporate? And just picking one is helpful because I think it can be super overwhelming when you hear all of these things, but having an action plan for something you are going to work on specifically that day or one of these strategies going in can be helpful. Then you're at the beginning of the shift. This is where you're really setting the tone. This is where what you do and say with your learner can really make a difference in terms of creating a safe, psychologically safe learning environment and setting them up for success. Even just taking 5 minutes, if it's somebody you've never worked with before, to just learn about them. Where are you from? What are your interests? What are your career goals? Not necessarily teaching, but it just shows your intention to get to know them. It shows them that you care, and it can kind of make it a little less intimidating for them. It also helps set them up for success. I think all of us have different preferences for how we like to teach and run shifts. Some faculty like to hear about patients right after a resident sees them because you may want to intervene if you need to change their plan. For other residents, you're like, I don't want to hear about it until you're ready to, click the discharge button. But there's a lot of anxiety among our learners because they can't read your mind. They don't know what you want. So thinking about what those things you like to see in your learner and what helps you run the shift smoothly and articulating them to advance, in advance can really help set them up for success. And then collaboratively helping them to identify a goal is really critical. I don't know about you all, but sometimes I get to the end of a shift, I'm exhausted, and I'm like, what? I don't even remember anything about the shift to give them feedback about. I'm like, I honestly can't think of a single thing. If prospectively you work with them to identify a goal and say, this is something I'm going to pay attention to during the shift and give you specific feedback on at the end, it normalizes that feedback is coming, and it can make you kind of focus on what to watch out for and then anchor your memory. You can revisit that at the end of the shift and say, this was the goal you set out to do this shift, and this is what I observed in terms of your progress with that goal. when you're mid-shift, you're grooving, you're seeing patients. This is where the meat of the teaching opportunity lies. And I like to think about it in terms of teaching opportunities when you're seeing patients, when you're staffing patients, and then also when you're reviewing results. Direct observation is truly the holy grail of competency-based medical education and workplace-based assessment. But how often are we actually going into a room with one of our learners and watching them do patient care? A lot of the ways that we're assessing them is just hearing them present a patient to us without really actually seeing how they made those decisions, how they collected that data that led to their clinical reasoning, and how they communicated to the patient. Actually going in the room, especially if you have downtime, and watching them through that process can be really valuable. You can actually see how they're taking a history, how they're asking the questions, how they're doing their physical exam maneuvers, how they're communicating and responding to questions from the patient. And that can really enhance the richness of your feedback. Now, I think it's important to mention here that sometimes people can feel very uncomfortable when they're feeling watched. So kind of letting that be known before you do this is important for kind of normalizing that discomfort. But explaining the rationale, say, I want to go in with you and really be able to give you rich feedback, and seeing you in action is going to help me do that. And then thinking about different staffing models. So a lot of what we do, we don't even think about it, this traditional serial staffing model of seeing patients. We send our learner in there, they take a history, they do an exam, they present it to us, and we basically go in there already with an idea of what's going on, and we're just going to try to confirm or refute that idea. There's actually alternatives that you can do to this. So a couple of them that we've published in AEM ENT have been really helpful and can actually be interesting to switch it up, especially with more senior residents or when the department's busy. One of those is the parallel encounter. So this is where the attending and the learner actually see the patient independently. They independently take a history and exam. And then they convene for the discussion, rather than the learner presenting to the attending, they convene for a discussion focused on the assessment and plan. And that actually increases the efficiency of the teaching encounter, because you know that they already know how to report a history and exam if they're a senior resident, but it gives them more time to really focus on the clinical reasoning piece. And you kind of collaboratively discuss that plan. And it also helps limit cognitive bias, because rather than you going into the room with an idea of what's happening, you've had an independent opportunity to assess that patient. One really critical piece here, though, is as the attending, you can't tell the patient the plan, and you have to make that known. You have to say, I'm going to go back and discuss with my resident, we'll be back, because otherwise it can be perceived as you stepping on your learner's toes. The other model that I think is really helpful is the teacher as scribe model. So this is where you as the faculty member go in with your learner. They are seeing the patient, they're narrating out loud their exam findings, and they actually are taking a stab at independently telling the patient the plan. You as the faculty member are on the computer, you're reviewing the chart. If they have questions about their past history, they can ask you can pull it up. You're scribing, so you're actually doing the note for them, which, surprise, surprise, they really like. And then as they dictate out loud the plan or discuss the plan with the patient, you can actually put in orders. So at that point, as long as you agree with the plan, you've essentially already, staffed the patient listening to what they've said and kind of putting in the orders in, and the notes partially done. So this can really increase efficiency. Now you can imagine if the patient's less straightforward, or if the learner is more junior, this may not work as well. So you need to have kind of a key word to say, before you go into the room, okay, resident, if this gets sticky or you're not sure what to do, you can just say out loud, my attending and I are going to step out of the room, discuss your case, and we'll be back to share the plan. That way they have an out if they don't feel comfortable in this particular scenario suggesting the plan. And then in terms of other teaching opportunities during staffing patients, you're going to hear about a lot more from my colleagues. So I won't go into detail about the Socratic method or the what if, because you'll hear about that more. But teaching scripts is a really useful one. How many of you have heard of teaching scripts or use them in your practice? Yeah. What kind of prompts do you usually? Oh, yes, that's okay. Any others want to share common prompts or triggers that they have for teaching scripts that they use? I have one for syncope. So anytime I have a learner that presents a case of a patient with syncope, there's like certain key points that I want to go through with them. How do you know this wasn't a seizure? How does the differential vary if this is cardiogenic versus, neurogenic syncope? What's the most important test you would get in a patient with syncope? Those kind of things. So they're nice because they can be automatically triggered by common scenarios that you see, and you can have them memorized so that they just kind of roll off your tongue, and you can tailor them depending on the level level of your learner. So if it's like a medical student, you may share more simple content. If it's a senior resident, you may share more sophisticated information in your teaching script. For board review, we actually had an attending, Will Moyer, who would carry around with him a stack of the Roche Review board review cards, and he would not let a resident staff with him until they would answer a board review question. And you know what? The residents liked it. It made sure that they were incorporating this into their day-to-day, and they appreciated that. And then real-time utilization of FOMED. Sometimes you don't have a teaching script. Sometimes you're seeing something that's weird or rare. I like to pull up WikiM, which is like one of my favorite resources. I'll search, the chief complaint or whatever the condition is, and it automatically pulls up a teaching script for me. We can go through it together with the resident and talk about what the key differential is, what kind of tests you should order, what the treatment is. And that can be really helpful because it takes the pressure off you to have to remember all of that. And I like it because I learn. It helps me refresh my memory on things. And then reviewing results. Anytime you have an imaging study come back or an EKG, really going through the process of interpretation with your learner, asking them to show you how they systematically review that, and giving them feedback on that can be really helpful. At SAEM, a really innovative technique that I appreciated at one of our sites was that as the off-going team was leaving and the incoming team was coming on, the off-going team, senior resident, would pick the most interesting case of the day, usually a critically ill patient, and they would present that oral board style to the incoming team and have the incoming team kind of work through the case. But this would be based on an actual patient that the off-going team had seen. They would present the EKG, go through all the data with them, and that was really nice because it was a way to make sure that both teams were getting some teaching, and it actually would be helpful for helping the off-going team process and kind of solidify the learning that they got from an interesting case. And then after shift, making sure that you make time for exchanging feedback. I like to call it a debrief session, and making sure that it's two-way, both you're giving feedback and receiving feedback on your teaching from your learner. And just as they should reflect upon that feedback and generate an action plan for the future, so should you. You think back to that goal that you identified for what you want to incorporate and think about how you might adjust your approach based on this experience for the next shift. And with that, I will I forgot, we're actually going to do a little activity after this. Now that you've heard kind of a quick overview of some of the different techniques and strategies, you realize it's probably not comprehensive. All of you probably have your own techniques, things that have worked well for you. So we're going to give everybody about 5 to 10 minutes just to discuss within your tables what are your favorite teaching strategies on shift, especially maybe ones that weren't covered here, and kind of learn from one another. And then we'll move on to the next phase.
There's pros and cons. I think it does allow me to use I'm a rich choice.
Something, the residents all know, all interns and all medical students and all interns presented these things. That's I don't characterize who you are, and then I involve the patient. I go in, I say, it's going to be an encounter. Your doctor is going to tell me all about you because I'm and I may also examine if that's okay with you, and I want your feedback on this too. And they know this script, and some of them have presented it. But anyway, they know what happens to everybody. And then we go, and the first time I meet a student or a resident, I go in with unless I know them. I watch them, basically watch them. Is it okay? And that works pretty well. And then so far, like all of a sudden they're that's not right.
Yeah, I try to incorporate them.
I'll let you know if I have a problem,
being a resident,
you know, and, yeah, you're just
absurd hours, you're being put in million directions. I don't think that is always,
I love that.
you don't always condition like a really specific idea of what you want to work on. Sometimes like, I just want to see my time, which is just tough. And sometimes it's like, I don't know, chest pain or something, like,
I mean, it makes it.
I think it's somewhat
It makes it so you can't do that like for
I
life.
do that myself as a resident,
Right, so.
and so like sometimes I can actually spend the first 5 or 10 minutes of the shift, actually trying to get that into process like that, like really write down what a smart goal is, and like say, hey, what are our objectives today? Make them tangible, make them something we can actually obtain. And one of my biggest issues I had was actually getting derailed by like 1 or 2 different cases, different patients, and then losing focus on what that topic was. And so I had to try to incorporate like actually setting a time somewhere in the middle of the shift at like in the shift, setting the time in the middle of the shift that like we're going to touch base, even if we're making all that directions, like see where we're at. Maybe we haven't accomplished it, or maybe it's really going off the rails, or maybe it needs to change. I do try something you brought up earlier, or Dr. Schnapp, on Phoenix, feedback. It's no longer like, oh shit, Dr. Max has pulled me inside again, and my shift's like totally up. That's an expectation. And like bring a lot of luck. And I just think that and it's not something, and so residents now, expect it's the annual walk that we run out on, usually cafeterias, but
we're trying to do it for.
There's an expectation that you're receiving that morning shift, regardless of how disruptive shitty that shift was.
I think it's interesting too that when you said like residents don't often come to shift with the goal because like in my current director, like I'm 100% it's like kind of challenging. But like I just know I would walk in the shift and the first thing I do is get somebody as like what you're doing today. And so like I like often spend the time from like the parking lot. Yeah, my like since I was an intern and I realized like just because I'm working people are going to ask me this when I walk in, my walk time from the parking lot to like the ED is like the time when I think about like what I want to work on today. And they like don't let us get out of it by like saying like, oh I don't want to suck. Like you have it has to be something that's like very, or if you say I want to push volume but it's very important, they're gonna say, well that's probably not a good goal today because like there are 4 open notes. So why don't you come up with something different? And I think like, also just, you know, over time, culture changes, but like, as a resident, I like doing that, like, because still as what is my goal?
Is it like as part of your team sign out that that's like everyone says it from everyone else?
Yeah, so once we usually will do sign out with photos and not going to to go see other patients and stuff without feeling all right, so what's your goal for today?
What sort of things would you say?
Bringing people back. Yeah, so like when I was an intern, I was like very bad at notes, and I found it was because I really hated seeing red on the board, so I felt very obligated to pick it up. And then I got myself in this spiral of like getting up a patient and seeing the staffing that couldn't get the next patient. So I would make a goal of like, before I staff with you today, I want to have dictated my HPI and my physical exam. And I will, and you will not allow me to staff with you until that is done. Okay. And that got me doing those things so I can be better.
Hey guys, we'd like to share the wisdom on the table. So we're going to go to each table and kind of get the highlights, if you don't mind, of what were some of the modalities that you guys described as far as using in your setting. So how about we start back here? First is the easiest. There's a lot of options.
talked about the idea that, about how great it would be to do the, something of some kind of oral boards, you know, to sign out the end of a shift, but that can be challenging because of the time and it demands of culture. Maybe a compromise is to choose just something cool from a case and not do like the whole oral boards case, but it's a cool EG and having everybody share that, so it gets 5 minutes, 10 minutes rather than half an hour.
Anything else that you guys can share? That was more summary. That was the best. That was the best. Okay. All right. How about you guys?
Yeah, we talked about having like little flashcards, like we do like contracts or visual diagnosis stuff, so that way at any time you just look them out and have to put that then to sign out, before sign out, or before the resident sends a case, kind of like trigger that to like think and simulate, and also just have like random recall, just kind of through repetition, hopefully just think it's.
I didn't mention it in our larger group, but one of the things we do is we have like a portable whiteboard, just kind of like in our work area. And so sometimes during day shifts, I work all nights, definitely like on night shifts, either if it's not busy or if it's, you know, so bored about it that it's not busy. You know, we'll try and do like some actual like direct teaching. Sometimes that's based off of something that happened on the shift. Sometimes that's something like pre-planned, but that actually works really well for us. It's really nice.
Setting the culture though, that's kind of what's expected to be able to spend the time doing that. How about here?
We talked about a few things. The one that came up that we talked, that was triggered conversation most recently, was about the sort of importance of a culture, setting a culture where residents or learners at the beginning of the shift, and probably supervisors at the beginning of the shift, can talk about their learning goals for the day, and then follow up on that. But how, when that becomes part of the culture, you can't sort of sidestep it, then you actually think about it beforehand, because if you know coming in the shift, somebody's going to make you.
I think Dr. Schnapp had mentioned kind of that expectation that like it becomes so ingrained in it that it's expected that they're going to get the feedback, you're both going to give feedback to each other, you're both going to have goals at the beginning of the shift.
Yeah, I think setting that environment, right, that learning environment so everybody knows what to expect. And frankly, when you don't start with asking what's your goal for the day, someone comes up to you, is like, I just want you to know my goal today is this, right? I mean, that's when you know you've achieved what you've set out to do. Because the learner walks in saying, Dr. Promes, today I really want to practice blah. And you're like, okay, we're on it. You know, but if you're not used to that, it's hard. You got to start somewhere.
Cool. All right, so we're going to, basically we're going to go through a couple of techniques that you may or may not have seen in terms of different ways to teach. And so this, we're going to do one, and then Steve's going to cover a couple more. All right, so this is strategic questioning. And so this is essentially Bloom's taxonomy. I don't know if people know Bloom's, but whenever you have to write learning goals, they ask you what your action verbs are. And it usually starts with kind of remember and understand, and then apply and analyze. So essentially, this is similar in the way that you're teaching. And so if you're trying to kind of uncover the knowledge or reinforce the knowledge that trainees have, it basically is asking questions at different levels. And so you might ask them a question such as, you know, what is the most common cause of gallstones in women? What is the most common cause of meningitis in neonates, right? It's basically kind of uncovering things to see what they know and don't know. And that level is really kind of a remember and understand. And then you might ask them, like, how does this drug work? Or why, how could you assess for a Rovsing's? Why is a Rovsing's sign important? But it's a series of kind of asking questions so that they are kind of demonstrating their knowledge or reinforcing what they know. I think you do need to be a little bit careful with it because it can be confused with pimping. So it is to say that you're not trying to get until they don't answer our question, and that it's done in a much more collaborative way. And the first level is kind of remember and understand. The next one would be apply and analyze. And so you can ask people to interpret something, they might demonstrate something, organize, question, relate. And so it might be something like, what would result if you gave TPA to a patient with an aneurysm, right? What would result if you did something? Or, what is the problem with giving X drug to a geriatric patient, right? And so you're asking them to kind of assess the situation, use the knowledge that they have, apply it, and move forward with that. And it is to say that there was a study of surgeons, and almost every single question was this, right? What's that? What's that? What's that in the operating room? And we probably are similar. Nobody's actually done it with emergency medicine people, but I think we feel more comfortable with the yes-no kinds of questions, a little bit less comfortable with the analyze and apply. And so encouraging people to really kind of get at that higher level of why is this true? What would happen? How is this similar to? That's the kind of compare and contrast. And then the higher levels of Bloom's taxonomy is evaluate and create. And so that's where it would be, the protocol is this, or the guidelines are this. How does this fit with the guidelines? The NIH stroke scale says this. Well, how might this differ in this patient because they've had a stroke before? And so really asking them to use knowledge and then kind of create new knowledge in the way that they're doing it. And those are questions that we might do. Okay. We're going to get you all to practice this. I'm going to keep it at the apply and analyze so that you got that, so you got that at your thing. So basically in pairs, so that you're doing it, can you just go ahead and choose a case? So either you all it can be a shared decision. Choose chest pain because that's the easiest thing. So your partner has presented a patient with chest pain, and you're going to ask them some questions that are trying to get to the analyze and apply level. Again. Okay, so your partner who you've been partnering with all day has just presented a patient with chest pain. And so you want to ask questions that get to the analyze level in relationship to a patient with chest pain. So what kind of questions might you ask if they're talking about a patient with chest pain? What are some analyze pieces that you might have? So what's the difference in presentation between aortic dissection and aortic aneurysm? Those sorts of things. Compare and contrast might be a good analyze one. So I'm going to go ahead and let you all work on that. Go for it.
So
And I just, you know.
What was uncomfortable?
I think it is operating a little bit, it's at a higher level, so trying to think creatively about the purposes of questions, and not just making up a question, asking a question, but actually making sure that you're coming up with something that's relevant to this discussion.
Yeah, I think this is hard when you first start to do it, right? It's really easy to ask a knowledge facts question. Really simple. You know, they either know it, they don't know it, and you can kind of teach from there. But when you really want to get to deeper level thinking, you gotta work at it a bit. And it does get easier. You know, once you start doing this and think about the level, this is great for that learner that a few faculty say they don't quite get it, but everyone else thinks they're great. And once you start asking these deeper questions, then all of a sudden it's like, ooh, I do see the knowledge gap. They know for, you know, chest pain to order aspirin, nitro, you know, order a couple tropes, get an EKG, repeat it. But if you try to dig any deeper, it's not quite where you want it to be. What about others? What kind of questions did you ask? Can you think of a question that you asked your colleague?
So in the, the setting of chest pain, a question all commonly asked by residents is, so you think this is cardiac? Compare and contrast how a pulmonary embolism would present. Why do you think this is cardiac? So it builds off their differential. And then the other question I really like to ask them is like, okay, if you think this is a patient with a heart score of 6 that needs to come in with a stress test, what are the problems with stress tests? What are they actually looking for? Does that apply to the pathophysiology of coronary artery disease in someone in this age group? And they're like, huh? But the answer is a bit for stress test.
Yeah.
So those are kind of the next level questions that I like to ask to get them.
Excellent. Other?
I think a really good kind of conversation in there is how do you make it not guess what I'm thinking, right? Read my mind and guess what I'm thinking. And that can be particularly difficult because you're asking them to guess what you're thinking. And so often the key with that one is as long as they are saying something that is correct, you affirm their correctness so that they aren't wrong because they didn't guess what you were thinking. And then you might ask another question to clarify. And so just making sure that as you get in this guess what I'm thinking game, that you're not and trying to open up to all of these places. Any other thoughts, comments?
Use it. Mine's kind of generic, but one of the things I'd like to ask the residents when they present is, what is this probably? And then what do I need to know it's not in order to safely disposition this patient? And then when they say, what do I need to know it's not, okay, what workup do I need to do, or what do I need to document in order to exclude that, dangerous differential?
Perfect. And now we're tossing it to Steve. Who's going to help with that?
No, that's a great setup. Yeah, and so in terms of the questioning, one of the things that I'd like to do when I was setting up this kind of questioning that Sally was talking about was actually saying that, this is going to give me an idea of where you are with your knowledge. So I know what I can teach you. And so I'm not teaching you something you already know. So I think that's a great way to do it. And so by setting it up like that, you're actually giving them permission to get to a point that they don't know the answer. And so that's a safe environment that you're developing. What I was going to talk about is just some of the exemplars or some of the things that we have found as a group when we were discussing that really work well in emergency medicine and what you can use easily while you're on a shift without a lot of thinking, without a lot of planning, just things you can do off the cusp. And so one of them that we all really like is called muddiest point. And so that's literally just asking someone, hey, we just walked out of a difficult resuscitation. What was the muddiest point or the most difficult part of that for you?
And it gives you an idea of where they are and what they found most challenging. And that can definitely differ not only from individual to individual, but also depending on what stage they're in their kind of development as a learner. So it may be that someone who's early on found that the most difficult part of a resuscitation was the use of drugs, or the order that things were done. And someone who's a little bit more advanced might find that the communication was the thing that they found most difficult. And so it gives you that opportunity to start a discussion around the area that they have difficulty with. You can also always throw in what was most difficult for you as well as a second opportunity when you're having that debriefing afterwards. Another one that we like is called PARS. And what parsing is it's a pause procedure that really lets the resident or the learner at the end of a case step back and reflect on what they learned from the case. So it comes down to two questions: so what and now what. So for example, you could start by asking, so what did you learn about teenagers are peds emergency medicine? Chris and I were joking here, the chest pain, when Sally said that's an easy bread and butter thing. We're like, no, not really. So forgive my examples, but it could be, so what did you learn about teenage females with lower abdominal pain? And let them reflect on that situation. And then the follow-up, now what? Now, what would you do differently in the future when you have someone who has lower abdominal pain? And the answer might be, that they were initially thinking it was appendicitis and it turned out to be PID, and now what could be that they're thinking to themselves, well, now in the future what I would do is I'd probably kick the parents out of the room and talk to the patient alone. So it allows them to pause and reflect on what they were doing. We had this mentioned before, I think Ben mentioned it, about the spit differential, but I absolutely love that. And I think it's a real easy thing to use in the emergency department. So that serious, probable, interesting, treatable kind of differential, especially when you find that there are a lot of residents who will come to you with one thing in mind, they say it very definitively, and you just want to have them step back and say, well, what else could it be? So again, in the peds world, the serious thing with chest pain could be like a viral myocarditis. But the probable thing might be that it's just costochondritis and nothing to worry about. The interesting thing could be something like hokum, and the immediately treatable thing could be something like pneumothorax. And so just getting them to think about what else it could be, even if it's not what it's going to be. It is another technique that we really like. The what if question is something that, especially in pediatrics, I love to use because I don't know the answers to a lot of these things, but they give the resident the opportunity to think about cases. So when we have a kid who has something going on, well, what if this were someone who were pregnant? What if this was someone who was 85 instead of 5 years old? What if instead of being a female, this were a male? Again, another way to get them to stop, think, and reflect. And again, pregnant people, 85-year-olds, not my thing, but it's always interesting to learn about. One of the other examples that I really like, and I found to be really useful, especially if I'm working a low acuity or fast track kind of shift, is the Aunt Minnie model. Does anyone know Aunt Minnie? So Aunt Minnie is kind of walks like a duck, quacks like a duck, is a duck, whatever that saying is. So, if you're in a small town and you see someone walking on the street, and from behind it looks like Aunt Minnie and they're wearing Aunt Minnie's dress and carrying her pocketbook, probably Aunt Minnie, it's probably not, name a famous person. And so it's good for those zebras. So the resident gets 2 sentences to say to you. And I like it, especially when you have those residents who are very, very verbose about things. 2 sentences. What's going on and what's your plan? So, I've got a 3-year-old who's coming in with fever, cough, congestion, and who has, bulging, not bulging, but like full pink bilateral TMs, my plan is to treat this like a viral infection, but send them home with a watch and wait prescription for amoxicillin. From that, you can jump off and use something called, thinking hats. It just kind of fits with that example that I just gave. You can use it as a standalone. But let's put on the thinking hat if this is the father or the grandmother or whoever brought this child in. What do they need to be looking for to know to fill this prescription for amoxicillin? Because this is probably different than what they expected. If you've got an ear infection, you just give them antibiotics, right? So what would be the things that they need to look for, and make the resident or the learner step back and think about it from someone else's perspective. Another time I like to use thinking hats is when I hear residents say, I can't believe the triage nurse didn't notice X or didn't bring this patient back with her. And so, it's an opportunity to say, well, what would you expect if you're the triage nurse to be thinking when you see someone come in like this, and have them think about something from a different perspective. And so those are just real quick, easy techniques that you can use in the emergency department that take no preparation. And so those are things that we would like you to try to practice here. So what we'd like you to do again is to pair up with the person you've been working with and have one person present something, just make up a case and start presenting it, and the other person use some technique to help guide that presentation.
Can you list your techniques one more time?
Sure, absolutely. So, mud harness measurements. Is the right one, harnessing the simple outlet, the spin differential, asking what ifs, and then hand in.
Steve, is that right? Is that... Is that right? Okay.
I guess the thinking hats, but that was.
Yeah. Yeah, because he was too quick. I knew they weren't going to catch it. Yeah.
So I guess chances are, right? One of the things, given all of those contexts, what are some of the things that we should that's where I might use once we got why is that?
Really have
It's just, this is not your level of exploring the world.
I honestly like, I'm happy
We're going to just real quick wrap up here. What technique did you decide to try out and why? How about someone back here?
I'd like to suspend disbelief type questions. So for me, a lot of them is, okay, so you come into this level 1 trauma center, we have all these resources. Let's pretend you are now seeing the exact same patient in Critical Access Hospital. How will that scenario differ? You don't have all this exceptions, you don't have all this things. How do you create?
Absolutely.
So suspending disbelief type questions.
Yeah, and that kind of fits with the what ifs, right? What if you were elsewhere? And that's a great way to use it.
Those are super important too, just because I feel like most of us, we're, by virtue of being in a training hospital, right? Like, that's the environment that you train in, and then the vast majority of people that's attending are going to work in that environment. And I don't know, that's a lot of your thought process, having worked a little bit in a clinical access hospital, is dispo immediately. How am I going to get this person out of here?
When you can't
I didn't have to do any of that.
Pinky specialist for that, right? Yeah, absolutely. Yes.
So we used the spit technique, but I'm not sure we understood what the value is of that treatable. Like, could you expound on what you mean by the most treatable?
Yeah, so you can use it as something that, you would need treatment for. So, with the chest pain and kits, it could be, you can treat it pneumonia. So that would be something that would be treatable. I like to think of it, though, as the immediately treatable or the life-threatening thing. So that's why I kind of use the example of pneumothorax as something that you could immediately treat. So something that you would need to do an intervention, or get a hold of someone to do an intervention.
Gotcha. Okay, that makes more sense.
How about someone over here?
We thought the eye in the spit was actually kind of cool because the learner would tell you something that you might not know, but then also they must have gone through the non-interesting things before they got to that list, so they thought about a bunch of stuff.
Yeah.
So it helps both parties.
It gives you that, probable, this is, what it most likely is, but also that zebra, that quick discussion. Unless you work at, who's worked at the county hospital and said the zebras are every day. How about this table? Interesting.
I think we did a couple. I did spit at first, and then we did a little harvesting, so what now, what kind of stuff.
Right. Perfect.
Yeah, I think I tried to be as unstructured as possible with my med student presentation, so I think I succeeded in that. So it was good to hear kind of the guiding questions to kind of bring it back in.
Yeah, absolutely. Good. So I hope you guys will try some of these techniques on the next shift. Sally?
And when you're too busy and it's bored and there's no case presentations, here's the answer.
I'll just use this mic here. Does it go back and forth? You should, yeah, you can do this or okay.
All right, so I'm just going to talk briefly. I think most of us in the room have probably been impacted by boarding. It's kind of the new way of life. I have a little bit of a different perspective as a still learner, and so I'm just going to chat briefly about some kind of ideas to engage learners in an environment in which you are dealing with boarding. We know that boarding has kind of led to emergency medicine residents, or maybe residents in general, just seeing less patients. There's changes in acuity of patients because there's just less flow kind of through the emergency department. And as a result, maybe decreased learning when residents come in for their shifts. This paper down here, I just want to give credit, Turning Lemons into Lemonades. A lot of this information kind of comes from that, and there will be a QR code kind of at the end if you're interested in any of these ideas. And it kind of breaks up different ways you can engage learners by kind of different categories. So learning from present clinical environment, this paper was also written by a bunch of people from my program, and so I've kind of been on the receiving end of a lot of this, and a lot of them are things that I really enjoy. So walking the board or reviewing waiting room patients, this is something that we do really frequently when there are like no patients to be seen. I'm not sure, we have like a medical screening process, or PIT medicine essentially, where patients will get screened, they will get labs done, and then there will be a bunch of patients in the waiting room with labs that have come back. And it is not uncommon for an attending to say like, let's look at the waiting room and kind of decide like, what was their chief complaint? What did they come in with? Like, what do their labs look like? Like, what would you do next? I think that's a great way to kind of engage learners, or kind of triaging patients, right? Like if you only have one bed that comes available in the emergency department and you've got this waiting room full of 30 patients, like who are you going to give that bed to? Case-based learning, I think we're probably most familiar with kind of oral board style cases. My program uses something called like Hit the Box, which is on our Taming the Shrew website, and it's just kind of a repository of cases that you can pull out at any given time if it's like very slow. Cash for Cases, has anybody ever heard of this? Used it? It was one of my favorite things as an intern. It's basically oral board style casing, but you make it into a game, and every kind of learner that's participating in this oral board style case, they get a certain amount of money. So you get like $100 a piece, and different things cost different money. So if you are like asking questions, you know, taking a history and asking questions, you might pay like $3 for every question that you ask. Each lab costs a certain amount of money, and then like the big things that we all love, like CT scans, they cost a lot of money. So like maybe $75, and so the learner has to be very thoughtful about the things that they ask and order in order to come up with like the diagnosis and kind of what they would do with the patient. I think that's a super fun thing because we're all super competitive because you win when you have the most money and you got the right answer. And so you're more thoughtful about the things that you order. And then kind of practical and procedural skills, so procedural competencies. This is super fun, especially for junior learners that may have not had a lot of procedural experience. We have like phantoms at our program, so pulling out like a subclavian phantom and saying like, I know there's no patients to see, let's practice subclavian lines. And you kind of hit a lot of things with that. You hit like the actual procedure itself, but that's another opportunity to actually go through the central line kits with the individual, kind of familiarize them with the kits. And then practical skills and interdisciplinary learning. I find that this like makes like other staff in the department really happy. The nurses like want to be a part of our education. They choose to work in emergency departments with residents. And so learning different things that they do, like putting in IVs without an ultrasound, asking them to help you with an help teach you arterial line setup, because you never know. I'm currently moonlighting in the VA, and like I needed an A-line setup, and like nobody really knew how to do it. And so like it's good to have those like practical skills to be able to do it. And then the last thing that I will say is like as residents become more senior within the program, I imagine that it can feel more difficult on how to engage us, just because you kind of reach this where you're like in your groove, you kind of know things. And I had a shift recently where there was a lot of boarding, and my attending said, my goal for you today is every patient that you dispo, I want you to tell me if you would have billed critical care time on that patient, which is like something that you actually don't think about, but I also don't know a ton about, right? Like you kind of just get that in the real world when you get out. So just kind of being creative and innovative and capturing our learners in the setting of like maybe not a ton of patients to be seen.
Awesome. Thank you, Jazmyn. A couple other categories where these strategies can be helpful. One of them falls within the workflow, task management, and QI kind of operational space. So when the ED is crowding, it often offers us the clearest window into what the bottlenecks and the challenges with our system are. And you can use that as a teaching opportunity. So perhaps looking at patients who've had the longest length of stay, reviewing their course with your residents and saying, okay, what's the bottleneck here? What is keeping this patient from moving forward? And then actually brainstorming what they might be able to do to move it forward. So let's say there's a patient who's been waiting a really long time for their labs to be sent because their nurse is busy managing the boarding patients and they don't have a line yet. Maybe then that resident can actually do something about it and go place an IV in that patient and move things forward. Along those lines, sometimes systems level proposals can be brainstormed based on this. So thinking about what are some themes we're seeing here with why things are backed up, with why people are boarding. In our shop, we noticed that patients who needed an interpreter were often having a much longer length of stay. And that actually resulted in a proposal to improve the capacity of in-person interpreters. So sometimes these things can actually result in actionable change. And then as Jazmyn mentioned, not only can you screen the waiting room and kind of talk about theoretical aspects, but under the supervision of a more senior resident or the actual attending, you can also use that as an opportunity to actually have that resident put in orders on waiting room patients and initiate obvious things that need to be done. Medical direction is often another opportunity that at a lot of shops only the attendings are really doing. A lot of the faculty might be taking those EMS calls, but pulling a resident into that and saying, hey, why don't, with my supervision, you listen to this med control call and you develop a plan and I'll give you feedback on it. Or just using that as a launching point to discuss nuanced things like EMTALA and various scenarios that can get a little dicey with EMTALA. It also offers you the opportunity to really dig into your residents' workflow. I think this is something we often don't have time to observe and give them feedback on. So observing them biopsy a chart before they go see a patient and actually watching what their EMR setup is. Are they using the filters and Epic? What notes are they going to first? Are they missing things? Or is there an opportunity for them to do it more quickly? That can actually be super helpful and feedback that they may not otherwise receive. Along those lines, documentation. A lot of our learners don't really get detailed feedback on their documentation. And I know that many faculty just sign the notes without actually reading them. This is an opportunity where you can actually have that patient have that learner document in real time on a patient that you saw together and go through their note with them and give them focused feedback. And then simulating high-level multitasking. So let's say your resident is typing a note or doing something, you actually simulate an interruption and say, okay, hypothetical critically ill hypotensive bradycardic patient comes in, what are you going to do? How are you going to address managing this patient, making sure things get done with your existing patients? Walk me through this oral board style. What are you going to need to say to your nurses to be able to step out of the room? At what point are you going to be able to step out of the room? And how are you going to make sure that things don't get dropped on your existing patients? Can be an opportunity. However, you want to make sure you're not actually interrupting them from doing important patient care activities. Evidence-based medicine is often something, too, that can get neglected in our teaching. And when there's downtime, it offers a rich opportunity to delve into that. So really using it as an opportunity to focus in on what clinical questions are coming up based on the patients that you're seeing and allowing the resident to work on skills like generating a focused search and talking them through the PICO format, watching them actually do the search, asking them to interpret the results of a study or talking about how you might assess the validity or quality of that study, and then having a discussion about how you would take the findings from a study and actually use it to affect your practice. And then also summarizing relevant literature based on an actual patient you're seeing. Let's say there's a patient with DKA, having that resident then briefly look up the literature about whether or not an insulin bolus is indicated in addition to a drip and talking you through the summary and the evidence behind that. And oftentimes it's helpful just to lower the threshold to utilize these strategies. Sometimes it's boarding and we're twiddling our thumbs and we're just not thinking about what's available to us to use that time wisely. Jazmyn mentioned at Cincinnati they have this wonderful repository, which is their residency program blog, but you could also consider creating a Dropbox or some sort of shared folder on a Google Drive or a SharePoint site, printing out a little Post-it or piece of paper with the QR code and posting that on the workstations, and you have question boarding and then link to this QR code for teaching opportunities. And that just reminds people to do it and can make it it a part of their practice. And this QR code links to that awesome article, Making Lemons with Lemonade. So if you want to access that and keep it in your back pocket, that would be another good one to put in a Dropbox so that people pull that up when you hit a certain threshold of boarding in your emergency department. And that's all on that subject. So with that, we'll hand it over to Jason, who's going to talk a bit about AI.
Depleting my battery, so I had to charge it enough in the back to survive this. All right, so we're going to spend a little bit of time just playing with AI and going through some demonstrated examples. Who here, just to kind of take the temperature of the room, who here feels really comfortable with AI products that are out there right now? And I just want to know so that I kind of know the audience.
Who's ever gone and done something with AI? Okay, good. And who's never done it with AI? Just in the open student. Okay.
All right, so bear with me for a second. I'm going to make this interactive, and I want to do real-world examples.
Do people have other things that they use for boarding, other teaching ideas for boarding? Actually, who's not tailored for who's just checking. There are places where they don't actually. Yeah. What would be other things that you're looking at?
No, it's just not recognizing my computer.
What do you
I'll try your dongle if you and see if it'll play nice with that. I may have to use a laptop.
Using hallway then. What else? It's hard. Clearly, I think there's a need for more things or more. So there is the dongle. Everybody check your dongle. I'm just fine.
There are some projectors that just don't like Macs, so. All right. Sally, you good? Or do you have anything else? Okay, so we'll just start with like a brief overview of what AI is. So AI in general, artificial intelligence, we would argue right now we're really not quite at the actual intelligence level. What most of us think of as AI is what's actually called large language models. And the way those work is they just basically have ingested everything that has existed on the internet up until the point that they finish training the current iteration of that model. And when you ask a question of a large language model, what it's actually doing is it's creating what it thinks is the next best word to match what you're trying to do. So it's literally building an answer word by word. So it says, here, I'll just, we'll see if I might need to make this bigger, so we'll see. What should I teach educators about LLMs? So as it builds this, it's actually guessing what the next word should be following the word in front of it. And it does that based on the assessment of millions and millions and probably billions of structured sentences to take its best guess. So when it goes through this process, it can do it better or worse sometimes. And if you ask the same question twice, you'll get two different answers too. So we'll see how it laid this out, introduction to LLMs, the technology behind it, applications in education, ethical considerations. So if I go back and I ask the same question again, it's going to generate a different answer. So that's something to keep in mind. So now you can see it's structured differently. It has some of the same content, but it's all delivered in a different fashion. So if you're using a large language model to help build a curricula or to try to write a letter of recommendation or something like that, if you have an answer that you kind of like, you should store that answer somewhere. So you, on the left-hand side here, if you subscribe to ChatGPT, which is probably the most popular model right now, I have a list of things that I've done here. So you can keep this list and you can go back and look through your prior chats. So this is one of the strengths is every time you do it, it's new, but that's also can be one of the weaknesses or vulnerabilities about ChatGPT. So the other thing that you need to learn about large language models is that it's not the question you ask initially, it's how you iterate on the question you're trying to ask. So this for example, I can say, I like the bullet points actually, but I can say, make this in paragraph format. Oh, nice. ChatGPT's taken over.
When it has a seizure like that, does it respond to phenobarbital?
It does not. Maybe it won't respond at all. We'll see here. There we go. Okay, so now you can see, so I have the initial bullet points here. If I ask it to change its format now to paragraphs, it'll change it to a paragraph format. And then I can actually say, do this in 150 words. So the point is, it's not the initial question you ask it always, it's how you iterate on that question where the real strength in this lies. Because I can just go through this over and over and over again and iterate numerous times with no effort on my part other than to read the iteration itself. So downsides to the chatbots, some of them that we can think of. One is hallucinations. Are you familiar with hallucinations? It really doesn't like this adapter all that much. It likes it more than my HDMI, which it doesn't work at all. But so hallucinations are when a chatbot makes up material on its own because it either doesn't know the answer and so it lies, or just as you go through iterating on things, it'll start to confuse itself, and they say that it's somewhere around 40 iterations. You'll increase the propensity to hallucinate. So ChatGPT now just came out yesterday, as all things tech, with a brand new model that I barely had a chance to play with. So the current models that exist for ChatGPT are 3.5, that's the free version that everybody has access to. You don't have to pay anything. You now have temporary access to ChatGPT 4.0. And it's like large 4, small 0, so it looks like 40, but I think it's supposed to represent 4.0. There's ChatGPT 4. So ChatGPT 4 is the model that you have to pay for. It's $20 a month. And with that model, you get 40 questions every 3 hours, and then it'll downgrade you to 3.5 if you ask more questions than that. And then with the current model with 4.0, which is what I'm using today, not that you can tell, the current model with that is that you get 80 questions every 3 hours. So you do have a cap. And as we talk about the plus minuses here, one of the downsides of these large language models is they're hugely energy intensive. So a search with a large language model takes about 10 times the amount of energy that a Google search would take. So we have to recognize that as we start to incorporate more of these, there is going to be a measurable environmental impact unless we can really start to power these plants in a meaningful, or in a more green way. So then the other part I'll talk about with ChatGPT specifically is they now have these things that they're customized bots, and you can actually make your own too. So what these are there, instead of using the whole internet as a resource, the customized bots only use the resources that are given to it. And so you could take, not that I would recommend that you copyright infringe on anything, but say you own a copy of Tintin Alley or Rosen, you could scan every page of that into a bot, and then when you ask questions of the AI, you can say use my Tintin Alley bot, and it will only utilize the resources that you fed it instead of utilizing all of the resources on the internet. So you can confine where it's getting access to resources. So that's what all of these are, and there's a couple of examples It's like PubMed Explorer is one. So, yep, sorry, go ahead.
Can I feed it my own work?
Yeah.
Okay, for example, I write an article and it's rejected from this journal because it's in the wrong format. Can I feed it my article and say, please rewrite this according to the format of the Journal of Irreproducible Results?
Yes and no. So a lot of journals now are asking that you not utilize, this is going to kill me. They ask that you not utilize large language models to draft your paper. So you'd probably have to speak with the journal editor to get some feedback on what you're allowed to do and what you're not allowed to do.
Just reformat it into their preferred format.
I don't know if you can speak to that at all, or. So Susan's our editor for academic emergency medicine education.
Right now, we ask people if they're using, any type of like ChatGPT, et cetera. We haven't turned anybody away from submitting something that way, but I think, as you heard Jason say, each journal is going to take their own stance on IAB.
So in this example now, I'm using a limited search bot. I'm using the PubMed Explorer. So all that they will utilize, all right, I'm gonna just have to switch their laptop. All that the system will utilize is content from PubMed. It won't look anywhere else. It won't create any hallucinations based on stuff it's finding on the internet. It'll only use PubMed as its resource. So as I convert over here again, questions from the group, we'll do a couple of tasks here shortly. What you're really doing is you're limiting its ability to find bad resources out there and give you bad data back. That's what that's doing. And I think, for example, when you're doing from a research perspective, like if you look back at some of the prior models, it would create references that were made up. And so it's to help eliminate that, not only references that are made up, but just unreliable resources. If we think about some of the alternative media and content that we have out there, it's going to prevent some of those things.
The thought is avoiding bad content isn't the same as having good content or best content.
I would say, in general, when using chatbots, you have to have enough mastery of the material to know that you have a reliable resource, and it can help sharpen your edge or hone something that you already have familiarity with. I also think it's really nice to assist with creativity to help you iterate on an idea. And I think a good example would be, let's see.
So just the hallucination thing, a friend of mine, when it was first coming out, she asked what precision education articles have been written in academic press. And it gave her 8 of them. Those were written by Dan Schumacher. And he has not written a single word. And it literally gave name, title, citation, everything. It was a complete hallucination. And so I think you just need to be able to how are other people using it? How are other people using it? Go ahead.
I've used it for, at least in my fellowship, I used it for discharge instructions. A lot of times, I think if anybody has Epic, there are coined discharge instructions for chest pain and things like that. Every now and then you have a diagnosis or something that you may, we had otitis externa that didn't have specific discharge instructions, and I typed into ChatGPT what are patient return precautions and discharge instructions for that, and it spits out something, and you got to read over it to make sure that you agree with it, but then just copy and paste.
Yeah, I think that's a great example of what to do with that. Yeah, stall for me, Sally. I did a great job of making a really complex password. So.
Yeah, so in Australia there's a scribe, AI scribe that records the whole conversation with interpretation.
That's coming, and places are using it, and so I think that's going to be really interesting. Yeah. It's kind of scary. Yeah.
letters of recommendation or recommendations for awards, that kind of thing. I know myself and others in my group have used that a lot. And it's really helpful because we can like preface things and set it up so you can see it right. I'm going to ask you to write a letter of recommendation for John after I give you some information about John. And then you can put in like, here's John's quick little CV, write me a letter of recommendation, and it'll incorporate a lot of that.
Yeah, I was going to give examples of that, but I have all my data on my computer and it's just not playing nice. But so what I would say with that, and some people will be like, oh, really, you're making these impersonal letters of recommendation? But let's be honest, 75% of letters of recommendation are impersonal anyway. So what I think of it as like a sandwich, and I let ChatGPT make the bread, and I make the meat. And by not having to make the whole sandwich and bake the bread, I have more time to focus on the meat of the middle. So your intro is kind of boilerplate, your outro is kind of boilerplate. What I want to focus on is the personal details of the individual in that middle paragraph. And another beautiful thing you can do with it is say, like, all right, iterate on this letter of recommendation and give me a better example, a smaller example, a larger example, make this 150 words, things like that, make it no longer than one page. And then you can also do nice things like, please, I say please, I actually type in please to ChatGPT. Be nice to our future overlords. You can say, remove passive language from this letter. And I know a lot of people have a lot of trouble writing in active language. So just by saying that, it'll remove about 80-ish%. It won't get rid of all of it. And even if you say, again, like, take out all the passive language, there's just some things that struggles with figuring out completely. Now, that's on 4.0 or on 4. I don't know about the new model here, what that's going to look like. And it looks like I need to put this over here, yeah.
I guess on a more relevant, I think you were I was going to say, I think I actually may have used it to start at least my like application statements for committees, for SAEM committees.
So I did an example for myself on my computer where I nominated myself for the Hal Jane Award, and that's to your point. You can feed it the template for the letter. And you can say, utilize this format, incorporate my CV, and write me a letter of recommendation for this award. And in 5 seconds, it writes you a letter, then you can read through it, and then you can add and edit as you see fit. And all it's utilizing is the data that you've given it. Great we were complaining about promotion letters. So you could, same thing, you feed it the template. So I did a letter for somebody that I won't name, and I just said, here's the promotion template. Here are the promotion requirements. Do they meet the standard or not? It gives you a recommendation, yes or no. And then I say, okay, then draft a letter for promotion for this individual based on their personal statement and CV. And you just upload all the documents. So that's one of the differences between the free version and the paid version. So 3.5 doesn't let you upload documents. 4.0 lets you upload documents. So something to keep in mind if you want to play around with 4.0. I mean, $20 is not bad if you want to mess around with it a little bit.
It's actually free. 4.0 is actually free.
When I say 4.0, I mean 4. I keep saying 4.0.
As of yesterday, so 4.0 is free, but your usage is severely limited. So
you're right. You're right. That's where you get the 40 and 80 questions every 3 hours, and then But I think we'll see what they do with that. Well, when you start to iterate, though, you can really burn through those pretty quickly, and then it'll downgrade you to 3.5. And I'll be curious how long they do that. I think they're trying to make a splash right now. I think you are next.
eBay offers you the option of using, I guess it would be ChatGPT to write your ad for what you're selling. And
so ChatGPT tends to be very verbose with a lot of like cursory language that doesn't actually have a lot of impact. So I kind of oscillate between using ChatGPT and then I plug it into Grammarly, actually, which has an AI filter built into it. And it does a really nice job. You can sort of set the tone for your audience. So it's like, hey, if I'm writing an email for my residents versus my chair, it's going to have a different tone. And it kind of takes that passive element out of it. The punctuation's appropriate. ChatGPT tends to give you a lot more verbiage. It makes it sound very, the tone's not quite right. So between those two AI platforms, you can actually put together, sounds a lot smarter than you are in person.
Yeah, and I like to utilize multiple chat models for different things. So one of the ones I use a lot is Otter AI, and that's for recording meetings. And so it's especially helpful if you start a meeting, everybody introduces themselves, and then it recognizes their voice from now on, and then it creates a transcript of the meeting. It'll actually tell you what percentage of time was spent speaking by each individual. And so, yeah, it's I had one meeting in particular where it was like, this person talked, it was like 5 people in a meeting, they talked for 80% of the time, and it wasn't our chair. Yeah, so it's kind of interesting in that aspect. And then it'll summarize the notes, and if you during the meeting, you say, make this a to-do, it'll then have a to-do list constructed at the end of the meeting for you. It'll try to make one on its own too, but if you're a little more specific about it, it'll make you a better to-do list. I think their summary in Otter AI is okay. So this is where I take Otter AI, I build a transcript out of Otter AI that I then upload into ChatGPT because I think ChatGPT does a better job of summarizing. And then I have ChatGPT summarize it for me. And that's where you can then say, make this bullet points and make it no more than 1 page long, things like that. So you can really iterate with ChatGPT after that. There's a way to do it in ChatGPT alone. I just don't think it's as convenient as the Otter AI is. And there's another one to the note of letters. It's from Goblin. And get the name here, I can't remember. It's called The Judge. So you take anything you're sending via text and you put it into the AI, and then you say, please judge this text. So like I did an example where I said, I need help with conference planning. All the other APDs are saturated, but you seem to have time to offer. We need July planned in the next 2 weeks. And then you run it through the judge, and it does a little thinking, and it says, based on the text provided, the message comes across as somewhat demanding and possibly dismissive of the recipient's workload. The tone suggests a sense of urgency and expectation for the recipient to prioritize this task despite the workload of their counterparts. There may be a hint of frustration or impatience in this tone, given the mention of a tight deadline for planning the conference. Overall, it conveys a sense of pressure and reliance on the recipient to fulfill this task promptly. So if you're somebody who feels like maybe that email is not quite ready for prime time, using the judge can help with that. That's from Goblin AI. We're talking a lot about ChatGPT because that's the model I tend to use right now, but Gemini is also a pretty powerful model from Google. I'm not a huge Google fan because I just don't really like the fact that I'm really the product for Google. Okay. Gemini, I've heard a lot of great reviews about Gemini, so if you want to try another product and you live in the Google world, Gemini is a great product as well. I just want to make sure I hit all my high points here. Sorry, we had a couple of snafus there. While you're talking, I'm going to do one more thing. So if you want to start wrapping us up.
Okay, we're wrapping up. Now I know what to say. About this topic, yes. So we thought it would be fun to ask, who's doing it, who's thinking about it. But part of it is also, I think that when we started looking at the regular search engines, so just Google, and you felt like there's suddenly an answer for everything. Remember when you used to kind of say, I wonder. Well, now you don't have to wonder. You type it in and it gives you an answer. But there's a downside to that because it's not always a good answer. I think that many of these models, and they are evolving really quickly, and they're using the AI then to drive other tools that you can use. But we thought it was time to maybe just introduce a couple of ideas here as where you are in education. Increasingly, there's unlimited information, but is it good information? And these models are only as good as the information that they're backing up, which is enormous. So you do see, why would there be hallucination? I'm sure it's like, well, she should have written this. There's going to be biases that come into some of these as well. I do know they're obviously working on those to try and limit those and get them out. But I think we still have to have a sense. I think these tools can help us be better at our jobs. I think they will be able to help us expand our thinking. But we do need to be able to say, how do you train people now to be critical viewers of this information? So that's kind of one thing that I think we've got to start weaving into our thinking and our approach, both for certainly trainees, but certainly also for ourselves. And the other thing was, we're laughing here about saying, I'm going to use AI to help me write a letter of recommendation. And we're like, awesome, efficient, yay. Are you going to let your students and residents use AI AI to write the personal statements. Because there's really no difference between them. I mean, this is a form of artistry. The prompts that you put in, how you realize what's important for residency and residency applications, the same way as you do for a letter of recommendation. They're very much the same. But you have people saying, you know, we don't want people using those, and we're going to see if we can pick them out. Apparently you can't yet. Using AI to tell whether it's other AI is not that good yet. I'm sure we'll get better. And so I think that we do need to be prepared to think about what is allowable in the use of this, and then try not to be hypocritical about what we say is good for me but not for thee. So those were just a couple of last points that I thought would be fun for us to think about in the future.
All right, we're coming back to, thank you.
And I think also, yeah, we'll let this happen. Recognize that what you send to these general large language models is not protected. So patient information, research data, make sure you're using a sandboxed AI. Like our institution has a sandbox 3.5. So it stays internal and uses only our internal data. So that's something else you have to be careful of when you're looking at that. And I think patient follow-ups are a thing that your residents are using these right now to do their follow-ups. So you should be aware of that. Yeah, so we can argue whether we think this is creative or not, but I don't know, that's pretty damn good if you ask me.
It looks a lot like where I work.
All right, so thank you, everybody. Hopefully this was useful. We're going to ask you to do the survey on your QR. So just scan, correct, each of us is going to come to your table. Please provide us some feedback about today, and then also what you'd like to see next year.